So, thank you all very, very much for coming today to this really important meeting, and thank you to all of you who are joining us online. This is, as somebody said just a couple of seconds ago, an iconic meeting. I am Nicola Bedlington, and I have the honour and pleasure of being your overall moderator today to guide you through this afternoon's very exciting session. And I also have the pleasure of being the FH Europe Senior Policy Advisor. Before we get into the meeting itself, I'm afraid, as ever with these meetings, we've got a few housekeeping rules. There aren't very many, but they are quite important. You will understand that we don't want the speakers to be interrupted, so we'd be really, really pleased if you'd put your phones on silent, but don't hesitate to tweet and use social media during the course of the afternoon. That would be fantastic. Could we have the slide on the housekeeping rules, please? The focus of this meeting is, of course, FH Paediatric Screening, moving prevention from evidence to implementation, really making it happen. And during the course of the afternoon, we'll explore pervading barriers and opportunities to make FH paediatric screening happen in practice, from political will and leadership, to cost effectiveness, both short and long term, to the agility of science, to health systems constraints, but also opportunities as we emerge out of COVID, and crucially, public trust and behaviour. The meeting will culminate in the Prague Declaration, which we'll also present a little later on today. But before all of this, allow me to introduce a number of key political and patient leaders who've been absolutely critical to making today's meeting happen. First of all, I would like to give the floor to Dr. Romain Krauss, our gracious host today, heading up the health department here in the Senate, a critical role, to say a few words of welcome. Dr. Krauss, the floor is yours.
Dobré odpoledne, dámy a pánové. Srdečně vás vítám v Senátu.
Good afternoon, ladies and gentlemen. Welcome to the Senate of the Czech Republic on behalf of our committee. It is indeed a pleasure to give my auspices to this extraordinary conference, which focuses on the question of screening FH. We have a very important meeting ahead. We will be talking about obstacles in FH screening, and I hope that these obstacles will be explained and overcome so that the screening can be implemented everywhere in the European Union to be available to children. This is one of the priorities of our presidency of the European Union. Screening is one of the key topics of diseases. There are other topics, oncology and mental health. This is one of the pillars of our presidency of the European Union. This is one of the events that are organized in the framework of this presidency, and I'm very happy to be hosting this debate. I hope you will find it useful, and I believe that at the end of the conference we will have clear goals which we will be able to fulfill. I will be very happy to inform both committees of the lower and of the upper chamber of the outcomes of this conference, so they can make sure all the outcomes are implemented, and so that we have all the necessary funding through health care insurance companies. I wish you a very fruitful conference.
Thank you very much, Dr. Krauss, for your unstinting support. FH Europe, as we know, has been instrumental in preparing this meeting in tandem with its Czech member, Diagnoza FH. Allow me now to give the floor to FH Europe's president, John Reeve, to say a few words. John, the floor is yours.
Thank you, Nicola. Deputy Minister Czech, esteemed guests, ladies and gentlemen. I'm delighted to welcome you to this high-level meeting on behalf of FH Europe and our network member in the Czech Republic, Diagnoza FH. The cooperation between us has been excellent, and I extend my warmest thanks to our colleagues here for their great work. I'd also like to thank our Czech Senate host and the Czech EU presidency for their unstinting support, and of course all of you for your participation and contributions. I'm very proud to be president of FH Europe. It's a growing network of patient leaders, allies and ambassadors who advocate on behalf of patients and people living with inherited lipid conditions, such as FH, familial hypercholesterolemia. This is inherited high cholesterol and affects about 1 in every 300 people. That's an estimated 2.5 million people in the continent of Europe, and 90% of them are unaware of it. FH is a common metabolic condition. It's a non-modifiable factor that greatly increases the risk of serious cardiovascular disease early in life. But there's a rare and severe form, homozygous FH, which puts even very young children at serious health risk. Every child with FH has at least one parent and several other family members with FH. So by testing children early, we can win the race against cardiovascular disease for them and their families, which is why our efforts on screening are so very important. FH Paediatric Screening might sound complex and difficult, but what we're asking for in simple terms is an early cholesterol test, a blood test, and only the very small proportion with high results, which is about 1 in 300, would need more comprehensive testing. We in FH Europe have spearheaded efforts over the last 4 years to highlight FH Paediatric Screening as a best practice. This was recognised by the European Commission, featured on their best practice portal, and it led to the technical meeting last October, supported by the Slovenian presidency of the EU. All this has created real momentum, and in 2 days' time, we'll have the pleasure of presenting FH Screening at a dedicated best practice marketplace event organised by the European Commission. This will enable Member States' representatives to learn more and to understand how and why replication and wider implementation is possible. Our focus today is on practical action and removing the barriers to successful screening. Only by really understanding persistent barriers of all kinds and how we can work together to remove them will we make the progress we aspire to. I'm very much looking forward to today's sessions, where we explore together how we can identify, assess and overcome these barriers and create the right environment for FH Paediatric Screening across Europe. As we'll hear from Professor Groschel in a few minutes, this meeting builds on last October's high-level technical meeting, where we achieved political and scientific consensus on the imperative for FH Paediatric Screening. And in the spirit of Jože Plečnik, the famous Slovenian architect who contributed so much to your beautiful city and its castle, we'll continue to build the case for universal paediatric screening throughout Europe and make sure it happens in practice. This will be our legacy from today's meeting. Today, I'm hopeful we'll be able to look critically at what we need to do to achieve our goal, recognising the respective roles and responsibilities of FH Europe, our network members at the national level, the scientific community, medical practitioners, insurers and policymakers at the EU level and in the Member States, and of course other stakeholders. Following this meeting, as we heard, we will publish our conclusions as the Prague Declaration on FH Paediatric Screening. This will be an important call to action addressed to national and European Union policymakers and decision makers. In closing, I would like to acknowledge and commend the Czech Republic's role in global efforts towards FH screening, since its participation in the World Health Organization's second report on FH and the creation of the MedPed program to make early diagnosis, prevent early death, which was back in 1998. It's very fitting that we should be meeting here today. Thank you.
Thank you very much, John. Excellent. We now move to the Czech presidency, and I have to convey the apologies of the Health Minister, Minister Valek, who was unable to join us today. He did want to be here, but has a very urgent mission linked to the presidency. But we do have the opportunity to welcome the Deputy Minister, Jakub Dvoracek. And I know from your previous life, Jakub, of your huge commitment to patient engagement and patients' and citizens' rights. The floor is yours.
Thank you, Nicola. And thanks to all of you that you managed to come to Prague. It's always great to see so many faces coming for such an important meeting. And I'm also welcoming all the people who are online. But yes, it's great that you are here, that we can host such an event, and I have this privilege, to help, with the auspices of the Czech Republic during the presidency for this event. So it's my big pleasure, and as Nicola said, I also have to apologize, Minister Válek. We have today and tomorrow informal meeting of ministers. So all the ministers of health are coming to the Prague. So he's now preparing for this issue, and I believe that part of the meeting will be dedicated to the discussion on the prevention and also to the creation of the plans of the Europe, to take care about the patient. You know that we have a big focus on the oncology during the Czech presidency. We're discussing the more precise focus on the goals of the European Beating Cancer Plan. But I believe, that such a tool as the European Beating Cancer Plan for the oncology, we need to create such a plans, for all the therapeutic areas. We have to connect all the therapeutic areas to the funding. We have to be able to say, what is important in the research, what is important in the development, but also what is very important for the patient to get the access to the new technologies, new screenings, new diagnostic methods. And this is something, what is, let's say, the key topic of the Czech presidency, if I take all areas where we are focusing. And we will try to do our best to promote the future planning and future, let's say, more detailed focus of the European countries on all therapeutic areas. We will try to do the best to move it also in the rare disease areas. You know that also the rare disease areas are trying to have the similar plan as the cancer. And I believe that the non-communicable diseases, they also need to get such a support. It's also important to mention it that the European Commission launched a new Healthier Together initiative on tackling non-communicable disease in Europe. And I believe this is the quite ambitious vision to deal with all those factors. And what is, I believe, one of the key topics, and it's one of the 5 pillars, is the cardiovascular diseases and explicit need for screening during the life course. For FH Paediatric Screening, it's one of the best practice example, and DG Sante Public Health Best Practice Portal. And I'm delighted that the high-level technical meeting in October last year under the Slovenian EU presidency explored how the Slovenian and Czech models together could bring the good practices and can be replicated around Europe. It's also important to mention that those policies and get the scientific consensus and it get the chance to move forward. During the Czech presidency, our focus is also to prevention, and all the topics which should be discussed today are perfectly fit, for the overall plan of the Czech Republic for our presidency of the European Council. What I would like to also mention is the key role of patient organizations, and as Nicola said, that's one of the topics which I try to promote here in the Czech Republic for the last 10 years. And the Czech Republic is one of the countries who really try to move a lot of decision-making power to the patient groups. The Ministry of Health established the Patient Council, which I believe is quite unique in Europe. So our minister and the previous ministers get the chance to have an official body where the patient groups are invited to provide the opinion, to provide the position. And from the 1st January this year, it's also quite a big success because we were able to involve the patient groups also to the decision-making process in the welcoming of new technologies to the Czech market. So the patients are now involved not just in the evaluation phase, but they are also involved in this decision-making phase. So all the orphan designated products are now coming through the process where the patients can say their perspective, and they are a significant part of this process. And I believe that also for the FH is important that the patient voice is heard and that the patient voice is involved, in future development of this area. What I would like to also mention it, and it's important that also Mr. Kraus name it as a key topic, it's a Prague Declaration. And the Prague Declaration, I feel, is something, what can move all that area quite forward. I can assure you that the Czech presidency will support it, that our minister supports this declaration, and I will do my best to push it forward. So thanks a lot for the invitation to our minister, to me, to talk on this event. And I hope that you will get a very nice meeting today, and that the final reading of the declaration and the final signature of the declaration will help the patients in the Europe with FH to get a much faster chance to be diagnosed. Thank you very much.
Thank you very much indeed for your very supportive words. Wonderful. I'd like now to give the floor to the President of Diagnoza FH, who has co-organised the meeting with FH Europe, Zdenka Čminicka. The floor is yours. Please.
Dobrý den, dámy a pánové. Zastupuji pacientskou organizaci Diagnoza FH. I mně je nesmírnou ctí, že vás všechny přítomné tady v Senátu, parlamentu České republiky, i vás, kteří se účastníte online, mohu pozdravit. Že vás mohu pozdravit jménem svým, ale především jménem pacientské organizace Diagnoza FH. Jsme tím nejnižším článkem v hierarchii rozhodování. Ale jsme to my, kterých se dnešní velké téma bezprostředně týká. Familiární hypercholesterolémie, onemocnění, dispozice, kterou jsme, my pacienti z FH, zdědili po svých rodičích.
Is a condition that we FH patients have inherited from our parents. Familial hypercholesterolemia is not visible. It does not hurt, it does not interfere, but then it strikes unexpectedly and insidiously with a heart attack or a stroke. And then it is down to emergency support and doctors to decide if and how our lives will continue. Yet it would take a little just to know about one's illness. Then we would be able to prevent it and treat all the complications and live life to the fullest. This is why we support the work of FH Europe, of which we are a proud member. We support the efforts of healthcare professionals across EU countries, the efforts to continue what was started during the Slovenian EU presidency. We fully support the introduction of blanket FH Paediatric Screening across EU countries. We appreciate today's meeting very much, especially as it takes place in these beautiful premises. It brings us together, it brings patients, doctors and other healthcare professionals together, and what's more important, it brings us together with the politicians, with policy makers who can actually change something. And we won't be successful if we do not agree on this with policymakers. Our FH diagnosis, awareness and education activities are sometimes challenging. There are obstacles. But we try to work not only with patients, we try to work with the public as a whole. And sometimes over a year, we discover 5 people or slightly more than 5 people who are suspected to have FH. It may not seem like a lot, but it makes us happy because for us it means that we have given a chance to 5 or more people, a chance to live a life free of cardiovascular complications. At the same time, it means that we saved money for insurance companies and maybe even for facilities in the social care system. There are 2.5 million of us in Europe, people who have FH, who are the bearers of FH, but only a small percentage of us knows about their condition. Only a small percentage is treated, but all of us have the right to live a happy, healthy life. So I urge you, please act. Please take the next step. Please make this declaration convincing. Because when you can prevent complications, why wouldn't you do it?
Thank you so much, Madam President. Thank you. So last but not least, the floor goes to Professor Urgreisle to take us on the journey from Ljubljana, where we held our high-level meeting, technical meeting last October, to our meeting today in beautiful Prague. Ur, the floor is yours.
Thank you very much. Dear ladies and gentlemen, it's a real privilege to be here for this outstanding event in the wonderful setting under Hradčany, which is, as mentioned before, also in the hearts of many Slovenes because of work of architect Jože Plečnik. It is almost a year since we gathered at the first meeting on pediatric FH screening under the Slovenian EU presidency, to whom we are immensely grateful to lend us their voice for our cause to solve the public health urgency. Even prior to that, we started to build on a best practices in collaboration with FH Europe organization, which was recognized by the European Commission and included actually I would say, most outstanding models, as is the Dutch one, the Czech one, and the Slovenian one. In Slovenia, over 20 years ago, measuring total cholesterol was mandated as an obligatory part of the blood checkup at the primary care pediatricians. So the starts were quite modest and quite gradual, but eventually we added also the next steps. We added genetic testing as a second step. We added a child-parent screening as a reverse cascade screening as a third step. And all the 3 steps are now approved by the National Health Council and also fully covered by National Health Insurance. And now this program, after many efforts in the last decade especially, covers and reaches over 90% of children. But of course, continuous education of all stakeholders is needed. It's kind of never-ending process. And also all other opportunities, even once you have universal screening, all other opportunities should be taken really to reach all the people out there, especially the adult ones, like with opportunistic and cascade screening. So it's really like, it should be like whole ecosystem adapted to the discovery of the people with FH. So 30 years after WHO reports, we obviously need new solutions, new tools for this old problem. And without a pediatric FH screening, it's impossible to detect majority of people with FH out there, which should be our goal. And we are more than happy that just a few days ago, public health recommendations on pediatric FH screening were published in the European Journal of Preventive Cardiology. which are depicting the recommendations from a Slovenian meeting, and also actually presenting the broadest, we could say, professional consensus on this topic, actually joining all the important international stakeholders. And now this document will be followed by Prague Declaration, which is enormous success. And we believe every country should have an FH screening program, which should be adapted from existing strategies to best fit the individual country healthcare system. It should be tailored according to the system each country has. And now with several possible approaches, I think we can offer each country the model which best fits that country. Governments should provide financial support for these programs, and the program should also be connected at the European level, as, for example, in the rare disease field, European reference networks are such very positive example. To conclude, FH screening affirms human right to health. It is saving and improving young people's lives and lives of their parents. So let's make it a reality. Thank you very much.
Thank you, Owen, and thank you to all of the opening speakers for setting the scene so beautifully. So let's move on to the next session, which is focused on political will and leadership and some of the barriers and opportunities here. And I'd like to give the floor to Neil Johnson, our moderator for this session, who is the architect and CEO of the Global Heart Hub, amongst many other things. Neil, the floor is yours.
Thank you, everybody. Good afternoon, and distinguished public representatives, distinguished guests, ladies and gentlemen. It's a great personal privilege to be here representing a patient organisation from Ireland and one of the founders of the International Alliance of Heart Patient Organisations, the Global Heart Hub. I have a panel, I believe, two with me here and one joining us, I believe, is that right, on screen? And I'll introduce those in a few minutes. But just to set the context, can I start by saying that clearly this is a very important event, and I'd like to congratulate FH Europe and Diagnoza FH as two patient organisations who are leading this initiative and are really making an enormous contribution to the task at hand. Today, as you already know, we're speaking about FH, an inherited condition which results in dangerously high levels of cholesterol. It has been described as the most common life-threatening inherited metabolic disorder in humans, severely underdiagnosed, less than 10% diagnosed, yet easily treatable once diagnosed. It's the most common genetic condition causing premature atherosclerotic cardiovascular disease and death. Screening for, detection, and diagnosing FH is fairly straightforward, and it has been recommended globally now for over a quarter of a century, yet we don't in Europe yet have a very clear strategy on this, and today's meeting is one step closer to that end game. As far back as 1997 in fact, the WHO recognized the importance of early detection of FH. World Heart Federation in 2020, the technical meeting of the Slovenian EU presidency in 2021, which was a very clear call to action, and really the meeting left everybody with the message that now is the time to act. And some European countries have begun systematically identifying citizens with FH. Among them, of course, your own country here, the Czech Republic, the Netherlands, Slovenia, Spain, Norway, and others. And while there are a number of ways to find FH, the evidence suggests that paediatric screening is the most advantageous and most necessary. Slovenia led the way with the mandatory cholesterol test at age 5, and they have now, I believe, something in the order of a 91% detection, which is really incredible. And under the EU presidency, the Czech Republic is spearheading an initiative to enhance cooperation and equity in the provision of FH paediatric screening across Europe. So some of the key messages we want to convey today, I guess, for those here and those listening. In a world of increasingly competitive interests, policymakers and decision makers will need clear answers to questions around the science, access, feasibility, cost effectiveness, and ethical issues before moving forward on a public health issue such as paediatric screening for FH. The FH community, however, together with the scientific community, largely has the answers, and now is the time to move forward. The wider cardiovascular health community is supportive. In fact, this issue would be viewed as the low-hanging fruit, so to speak, and could act as a catalyst in other areas of cardiovascular disease health. And there appears to be a positivity emerging at EU level to prioritize prevention and to shift the emphasis to cardiovascular health and away from disease. FH Europe is highly sensitive to subsidiarity. One size doesn't fit all, and the cultural, socioeconomic and political environment will influence the choice of screening programme. The key point is that we need to make it happen. And the purpose of this discussion today is to look at how we can motivate, activate the political will to do so. So I'm joined in the panel here this afternoon by Birgit Bieger, European Heart Network, representing European Heart Network, and the European Alliance for Cardiovascular Health, each. And I believe online we're joined by Dr. Slim Slama from the World Health Organization, WHO, non-communicable diseases department based in Switzerland, and Professor Michael Vrablik from the Czech Society for Atherosclerosis, the Czech Republic. Delighted to have you all on this panel. And maybe if I could start by just stating that, ironically, as the chair, I'm the one to put my hand up and say that in our country, in Ireland, rather embarrassingly, we don't have a strategy for FH. We don't have a screening program. We don't have clear pathways, and we have a very low level of public awareness. So I see it as my challenge, as it were, to now hopefully bring the patient voice to bear in our country. But here in the Czech Republic, things are far more advanced. Professor Michael, will you tell us a little bit about just how you're doing things and what the situation is like here?
Well, good afternoon to everyone. It's really great pleasure to see so many enthusiastic faces and such a great support from all the different angles. You know, we've been meeting a number of years among our research and scientific circles, then we took patients on board, and I think that today it's really something very novel, because we are not only among ourselves and patients, but also with the stakeholders, the payers, organizers, policymakers. This is what really is bringing the change into the era. And basically what Neil has alluded, we've done a lot here in the Czech Republic, and I can see faces who are responsible, and I wouldn't be calling them individually. But basically it's teamwork of plenty of people who really made it happen. So basically we do have very good grounds for selective screening in pediatric age. So basically our pediatricians, and I do wave to representatives of their expert society, and thank you for coming here. The pediatricians basically are obliged to test every child with positive family history of FH, or premature CVD, at the age of 5 or 13. And each adult general practitioner is also in charge of screening for cholesterol levels. We, though, believe that we should enhance and move forward. So what we've been doing, and I'd like to thank to the leader of Czech FH project, Professor Freiberger, who's on the panel later on, that we are the third, actually, in the detection rate globally in terms of number of identified individuals. And I'd like to be optimistic. We are 1/4 through, so 25% of the predicted amount of individuals have been already identified. So our system works. That might be one point of view. I can see Birgit's laughing. But yeah, I'm an optimistic person. So basically I feel that being third in the world is good. On the other hand, 25% means 75% undetected. And this is something we really need to change. And today's meeting is here to think about the next step. And I truly believe that universal pediatric screening, as implemented in Slovenia, I'm really proud to sit next to Ur, is the next step that we should all undertake to make it happen. So thank you very much, all of you, for your support and being here. And I look forward to further discussions.
And I think what you've said actually sets the context very well, because you've just compared Slovenia with yourself, different system. So the point being that we can potentially achieve the same thing in many countries different ways. And clearly we want to get to the optimal best practice, whatever that finally ends up to be.
Well, I think that this is something that we need to really state at the very beginning. There's not a universal approach to that. I think that we all can agree pediatric screening, universal pediatric screening is what we need to do, though how this is going to be implemented in different European countries would differ. That's quite obvious. So we are not pushing for one optimal system, because that would really differ in Ireland, in Czechia, in Slovenia. But what really needs to happen is to screen for FH during the pediatric period.
Yeah, so it's a key message, I guess, to come out from today, is that there are ways of doing it. It's not necessarily that this initiative is pushing for a definitive way of doing it, but that there are ways, and every country can adapt to that. Can I jump next to Dr. Slim Slama from WHO? And Slim, if you don't mind me saying that, I mentioned earlier that almost a quarter of a century ago, WHO identified this issue as a priority public health issue. I suppose the hard question is, why are we where we are today, given that that number of years has elapsed and we don't have widespread screening?
And I would like first to thank the organizer and FH Europe for inviting me to this very important meeting. I think all the preparatory session and what you have just mentioned set the scene, is that in anything in global health issues, is that you have a problem, a challenge, and you have policy options that need to be actionable by political will in terms of investment, but also into implementation. And often we need those three streams about the problem, the policy, and the politics to align. And this is what we call a political window to effectively, address the problem. I think what you have outlined has been that journey that the FH community, through the patient themselves, through their communities, through the primary care providers and the clinician community and scientific community, have tried to do in many of those countries in Europe, is to bring at the forefront three main elements. One is what people are experiencing in terms of burden. And I think many of you have stressed the need to really bring the voice of people with lived experiences. And we have seen it in the NCD agenda, how much has been neglected in the past. To be able to formulate scientific responses in terms of what is the natural journey evolution of this condition that has been under-recognized and under-treated in the past. And thirdly, the impact of and the solution that are proposed. And this is where we have a challenge perhaps in FH, is that it's about screening among a population of children, but also in their families, and how we set up evidences that can work in real setting. And I think we have probably a breakthrough with last year meeting, but also with the publication that illustrate that it's feasible, that there are responses. And these responses, as many of you have mentioned, need to be tailored to different health systems context. And global attention in global health are really around those issues, is who are the actors who frame this idea, how we mobilize different communities into one coherent narrative that bring the various stakeholders on the same page, and how we bring solutions that are actionable for member state and policymakers in terms of health system requirement, cost implication, and also service delivery models that are suitable. And I think the paper that is still, embargoed, I understood, gives some of those elements in terms of highlighting various expenses across European region. Of course, from a WHO perspective, you might ask us directly why this has not been more widespread globally. And of course, there are, competing interests, health system constraint, and specifically when it comes to screening, and also the evolution of the cardiovascular disease agenda over time, focusing much more on adult population, the use of cholesterol agent and lipid-lowering agent have changed over time as well. So there are various, reasons why we are not where we'd like to be, but I think you are making the case with this event that there are possible way forward and clearly actionable programs that have also building not from scratch, but long-standing experiences in Europe. As many of you have referred to the Healthier Together population strategy in Europe, the best practice portal, and the presidency of the Czech Republic in particular are really, stars that are aligning on the sky to allow this agenda to move forward. And I'll stop there now.
Can you hear me? Yeah. I hope I'm not speaking out of turn when I say that at this stage, I think there is a momentum which suggests that the clinical community, the patient community are aligned on what the solution is here. And we have examples of how this works. So in a short few words, could you maybe give us some advice as to how you think we could mobilize the policymakers globally? I might move on, if I can go back to you, Michael, if that's okay. So we have the science, as I said, and different countries are drawing on and adopting best practice, but there's a real sense that we're lacking political leadership in this. Your thoughts on how we will mobilize and activate policymakers?
Well, that's much better to be targeted to Slim, so hopefully he gets back. But actually, we have achieved pretty good collaboration, and I think that as there's very strong scientific background, we can answer most of the questions that relevantly policymakers are asking us, So basically, FH screening fulfills all the rules of successful screening. So it's treatable, the consequence can be avoided with available, accessible, nowadays even cheap treatment. So basically, I think that all these barriers have been gradually removed. And I must say that mostly we agree with our policymakers and even with the payers on the principles. Of course, implementation of, let's say, universal screening is also costly in a way. But once again, that shouldn't prevent us from thinking about how to implement it and how to do it in the best possible way in each different healthcare system. So I think that basically we've heard some hesitations and some questions even before during preparation of the meeting from Dr. Slama, but I believe that most of these questions have been already resolved and even published in the scientific literature. So basically we are in a very comfortable situation, I would say. FH has answers, or FH researchers have answers to most of the questions that policymakers finally ask. So I think that that has been more or less resolved. And within European space, I believe that we shouldn't be questioning cost-effectiveness issues, because it's beyond any doubt one of the most cost-effective strategies we have available.
Yeah, absolutely. And Birgit, reference was made earlier to the, this being the low-hanging fruit in the context of the wider cardiovascular agenda, being an almost guarantee of ASCVD if you're diagnosed with FH. What's your perspective in terms of European cardiovascular disease leadership?
I think, and therefore I was smiling when Michel said that he is optimistic, and I'm optimistic too, that we have a change of game here in Europe and an awareness among policymakers that if we tackle cardiovascular health, we'll step forward a big step towards more resilient healthcare systems, because it is the killer #1 in Europe and worldwide. So if we were to have a European plan for cardiovascular health, which includes primary and secondary prevention, we will have a decisive element to, on the one hand side, improve the health of all European citizens and everyone in Europe, as well as fulfill also a bit what the Europe inspires at global level for the global commitments. So I think having a European plan, there is the idea with the Healthier Together, the European Commission, that something needs to be done with NCDs and prominently in cardiovascular health, giving scientifically proven the role it has as a disease burden in the first place. Then I think there's also the inspiration to create healthier living environments, so having a holistic approach, and that is coupled with an investment in this early detection, because as you say, it's a low-hanging fruit. It decisively, it's always early intervention and primary prevention are two tools where we can really improve health outcomes quickly and cost efficient. So this is really something where there is immediate effect on the quality of life in Europe. So it is for policymakers really something to put into their heart to think about that. We have other positive elements like the potential of digital technologies for cardiovascular health. So we look into outpatient monitoring, telemonitoring, and I think helping detecting equally earlier and being on the ball when things go bad. And they are part also of a multidisciplinary pathway for the patient. So putting the patient in the center and surrounding him by a system which is bringing all the strands together is equally more efficient than doing a drop of water here and a drop of water there, and it will be all lost in the end. So I think we have a huge opportunity, and this meeting today shows if science comes together, policymakers come together, patients come together, then there is an element of co-creation which changes the landscape and to the positive. And I think this is the moment where we need to be optimistic and take the chances while we can. So in this respect, the European Alliance for Cardiovascular Health was created because we saw it is now time to act, and the European Heart Network bringing together the patients, they are strongly supporting this action and use the time while we have it to improve health and, let's say, literacy as well, because overall, we are looking also at health inequalities. This is another very strong element why we can't be still, because if we continue like we do, we will not have equal access, and we have the disparity within our society and communities, which will help no one and leaves people behind. So there's an urgent need to act, and I think the moment is now, and I have the great pleasure to be part of this optimistic development. Thank you.
Yeah, and each, of course, I believe is the first time there are 16 significant players in the cardiovascular landscape who have come together calling on EU policymakers to develop a European policy plan on cardiovascular disease, a bit like the cancer plan.
Yeah.
Are you optimistic that such a plan will be delivered?
Yeah, well, we all stand there together, and I think there is, as mentioned, there's no much alternative to it. If you want to be serious, you need to address cardiovascular health because it is so prominent in Europe. And I think what you receive as a benefit overall for European society in not only in health, but in the end, we are also talking about economic development. It will keep people longer in the job, having a longer life, more productive life, being there for children and as a caretaker. So there are only benefits, and I think that there is the understanding if we address it now in a structured, financed way, a plan, as to speak, we will be more successful in the end than to having these little short actions which are not part of a concept. And I think that is what we need in order to change things in Europe.
Okay. So positive messaging, and I'm conscious of time, so I'm going to move on and maybe go to a final question for each of our panelists if we still have Slim with us. But there's clearly a growing momentum on tackling FH in Europe. The Slovenian, Czech EU presidencies have elevated the issue now of paediatric screening. The clinical community is strongly making the case for public policy. 2 days ago, the European Journal of Preventive Cardiology has an article which very clearly makes the strongest possible case for screening. So can I just ask you to close this session, each of you, maybe start with you, Slim, if I can, just one key recommendation from your perspective on how we can galvanize political will and leadership. What role can the WHO play, for example?
Well, for us, sometimes we expect WHO to come out with all type of normative guidance on all aspects. And as you have seen, 1998, and we are now, several years after that, and we have not new guidance. So what I would say is that sometimes what is important is that we are learning from the advocates themselves and the scientific community, the people living with. And this is an example with FH where bringing that cohesive policy network is important. And specifically on the point that I was raising is that when you have any global health problem, you need to articulate solution and try to illustrate feasibility in various contexts. And this is exactly what you have done. I think what I found promising is that you have progressively addressed the various elements of global policy attention is how we move from the problem itself or being descriptive to articulate solutions that are feasible and show how these are can be implemented in various contexts. And then you have the broader frameworks about whether service delivery platform and who should be involved and where those interventions need to take place, and the broader policy framework. And you have with the in the context of the healthier together strategy in Europe and the cardiovascular potential plan that you mentioned, entry point also to make your case for FH. And I think these are very important alignments. So I will continue that advocacy work that you have started and many colleagues have started for several decades now, bringing the evidence and also the feasibility in countries. I think this is what should pay for. Thank you very much.
I think I would be speaking for the FH community when I say that given the momentum that is now clearly developing, support from the WHO is going to be very important. Birgit, again, and if you can, one recommendation. What do you think European institutions and obviously more than specifically national governments need to do?
Thank you. Yes, I think if we have a European plan as recommended by the European Heart Network and by each, if we have this European plan, then it will have a trickle-down effect with the creation of national CV health plans. So I think there's an inspiration for it. And as we discussed before, national plans need to be adapted to the national context and needs. So I think if we think in the big picture at European level, it is beneficial to national governments. It is like a toolbox, and this is the beauty of European cooperation, to find these elements to foster the health at national level too.
Thank you for that. And the good news is that we do have an example of best practice. I believe Spain has just launched national cardiovascular.
Exactly, brand new from the press.
Yeah, exactly. So again, we can take some inspiration from that. And finally, Michael, it's very clear that the clinical community are behind what we're about here, as are the patient community. But what more can we do you think?
Well, I believe that one thing has been said very clearly, and I loved it, and it's FH, it's screening, diagnosis, and treatment is a low-hanging fruit. So basically, yes, I'm totally for creating big frameworks for combating cardiovascular disease. FH is embedded into it, and it's low-hanging fruit. We can do it now, we can do it quickly, we know how to do it. So basically, this is absolutely clear that European organizations like each WHO European part and all the others need to get together. We need to exchange and learn from each other, but FH is simply a very nice example how we can quickly act, at least in this particular area of patients that definitely deserve attention.
Thank you very much for that. And in the interest of time, I guess the message for the policyholders, or policymakers, from this discussion would be that sometimes when we talk about cardiovascular disease, it seems so big and insurmountable that very often it doesn't get the attention it deserves. But today we've been talking about a particular part of cardiovascular disease, FH, which we now know is easily detectable and is treatable. And we also know from best practice that it can be screened ideally through paediatric screening. And I guess the message is that there is a momentum now, there's a positivity in the clinical community, in the patient community, and we're really now today looking to the political leaders to make this happen. There is plenty of examples out there. It doesn't have to be a one-size-fits-all, and there is something for everybody. So I hope that this particular discussion has contributed something to the agenda today, and I'll close this session now and hand back to you, Nicola, and thank you to the panelists.
Thank you very much, Neil, and all the panelists. The key word that I took from this session was optimism, so thank you both. Thank you all very much. So moving to the next session, cost effectiveness is, of course, a major preoccupation for governments, balancing the bucks also in this uncertain world. And I'd like now to give the floor to Dr. Inaki Gutierrez Ibalucia to lead us through this key session. The floor is yours.
Thank you very much. I'm going to say a few words if I try in Czech. So, dobrý odpoledne, dziękujemy za istotność maty. I don't know if I've said it properly, but at least I try my best. Some things to be said. Screening, a clear return on investment in the short and long term. It was 20 years ago that I was first in Prague, and I think it was a good chance to be back, and I have an argue that is promoting the Prague Declaration, and I think it is fair to be back. But I will remember when I was studying clinical epidemiology, it was around 2002, so 20 years ago. And I still remembered which were the principles of screening, and those were from Wilson and Jungner, and they were saying 10 principles that I think they are still valid, and they were saying the condition should be an important health problem. The natural history of the condition, including development from latent to declared disease, should be adequately understood. There should be a recognizable latent or early symptomatic stage. There should be a suitable test or examination. The test should be acceptable to the population. There should be an agreed policy on whom to treat as patients. There should be an accepted treatment for patients with recognized disease. Facilities for diagnosis and treatment should be available. And the cost of case finding should be economically balanced in relation to possible expenditure on medical care as a whole. And finally, case funding should be a continuing process and not a once and for all project. In 2018, that was written in 1968. 50 years after, there was a revised paper from the Canadian Medical Association Journal revising the principles from Wilson and Jungner, and they concluded on 4 domains. The first one was disease condition and principles. They referred to the epidemiology of the disease or condition, the natural history of disease or condition, and the target population for screening. The test intervention, so it is, there needs to be a test, and a screening test performance characteristics, interpretation of screening test results, post-screening test options, so you need to decide what to do with not just putting a tag to the patient, but also to decide what I'm going to do with him or her. And finally, having an infrastructure. So it is having a screening program, and a screening program coordination and integration, a screening program acceptability and ethics, a screening program benefits and also harms, if there are any, and also economic evaluation of a screening program, and finally a screening program quality and performance management. So if we go to the principles, and if we go to the revised principles 4 years ago, why we are not there? And I had a good health economist from Italy. He was working for the Research Council, and he once told me, if a public intervention is effective, it's always cost effective. So what about why we are not there? And I have a nice group of panelists I'm very proud of. I've struggled them a little bit because I've said no PowerPoint. You know that in Switzerland they have a party that is against PowerPoint. So I've said to them, no PowerPoint this time. So, and I've asked them to give us arguments in terms of convincing politicians and the citizens why we should, according to the principles of screening, why we should promote familial hypercholesterolemia screening. And in this regard, I'm very proud to invite, first of all, Albert Biefman, distinguished cardiologist and pediatrician, so with huge experience on familial hypercholesterolemia. In fact, he wrote a thesis on pediatric implication of heterozygous familial hypercholesterolemia. So give us some arguments. And I've said to them that they have just 3 minutes, and then they will have another reaction. So as far as they go further, they will have less minutes to do the final remarks. So thank you, Albert.
Thank you for the invitation, Ministry of Health of Czech Republic and FH Europe. And I'm proud to present the background of FH, especially in Czech Republic, because in the 90s, Czech Republic, Slovenia, Norway, and the Netherlands started to discover, and I proudly to present on behalf of all the children. It is the most frequent inherited disorder in the world. Every minute a child with FH is born worldwide. Even in our tiny country, the Netherlands, 2 children per day are born with FH. And like cigarette pack years, it's with FH all about cholesterol pack years, leading to cholesterol plaque years. In people without FH, this occurs in decades. In children with the rare homozygous FH, it occurs in months. We have 7 children on weekly apheresis, dialysis, to prevent them from a heart attack. And Europe lost in the past decade a dozen of children between the age of 3 and 6 due to a fatal myocardial infarction. In Italy, France, Germany, UK, Switzerland, Austria, and last month a 3-year-old child in France again. So there is an urgency for homozygous FH, of course, but the frequent heterozygous FH is in between and very well treatable with cheap drugs. So we did 3 major discoveries. At first, arterial wall thickening in heterozygous FH already develops before the age of 8 years. But also that fat can come out of the vessel wall as long as it is not calcified. So we compared parents with heterozygous FH who started at a mean age of 33 to their children who started 20 years earlier. And 1 in 3 parents died before the age of 40. No, sorry, 1 in 3 parents had a heart attack before the age of 40. And 1 in 10 parents died before the age of 40. And the children are now between 30 and 40, and none of them died or had a heart attack. So we were there with the statin therapy early enough in their teens. So that's a strong advocate. And even we can do more for children in homozygous FH. In the Netherlands, we had 63% of discovery, but it's still 37% non-detected, and they are at great risk. So we did a few major discoveries. Of course, plaque can be removed even in homozygous children. We now have a new drug, and they have, instead of weekly dialysis, once per 4 weeks dialysis, and have clean vessels. The plaques are removed. The second thing is we are in cost, for the healthcare perspective, cost effective, and I'm not an economist, so, and in societal perspective, cost saving, and we have a return on investment between 12 and 16 euro. So I hear that it's between 1,200 and 1,600% return of investment, or even better. And finally, what I can tell you, if you don't detect or don't screen, half of the parents will suffer from a heart attack at age 50, 55. If you only screen for adults, only a quarter of the parents will have a heart attack at age 50, 55. If you detect children and parents, you prevent them all. So I promise all the 4,000 children at our outpatient ward that they will become 100, but please not only these 4,000. Thank you.
Thanks, Albert. You will have 1 minute less. No, nowadays that we have framed the problem, and we have seen that there are some spaces in which we have good and success stories. And it is my pleasure to introduce Heribert Schunker, that he is a cardiologist, and not just treating pediatrics, but also adults. And nowadays he is the director of the cardiology department at the German Heart Center in Munich. So, Heribert, what about the tests and how they go, and what established in a successful program?
Yeah, thank you very much. The easy message is it's doable. I mean, you, the stakeholders, I mean, you don't have to any fear to carry. I mean, as soon as you give the starting signal, it's going to work. So the community, I want to say that is the parents and the children, as well as the pediatricians, they are waiting for it. And the only thing is to have to pave the road to get there. So how did we do that in Bavaria? Obviously, we had to convince the local government to give us the resources to build the logistics. And we did that by a comparison with cancer medicine. We heard that politicians, actually, they have a really strong impetus to improve the risks that come from cancer, but the risks from cardiovascular disease are even larger. And the P4 medicine, they can be carried out not only when it comes to malignant disease, but also to cardiovascular disease. So in the case of FH, it is predictive if we make the diagnosis. It's preventive, we just heard that. We have to do that in a community, it's participatory, and it's precise. We just treat those who have the disease. So it's a perfect case for P4 medicine. But of course, we have to come up with the logistics, which wasn't that easy. It took us 2 years to have all the information material, because we want to inform parents very well that that is something good that they're doing to their children. We had to overcome the legal issues if we do genetic testing. There are laws that we have to go by, and we have to set up a central infrastructure. That means data safety rules have to be taken care of. But once that has been done, this is something that is easily really brought to the community. Obviously, the communication is important towards the patient and patient organizations, but also to the scientific organizations and societies, but also the professional unions. I mean, for us as adult cardiologists, it was important to communicate with the pediatric pediatricians and the pediatric cardiologists, I mean, to come up with the infrastructure. So all this has been done. And why is it a good moment right now? Why hasn't it been done in '68? It's an easy answer, actually. Now we can make the diagnosis very easily, not only with the cholesterol screening, but also the genetic testing. I mean, we know that the treatment works, so we know why we need to do it. And I guess it is just something we have to do and get started with. As you just alluded to, it's an important health problem. We can take care of it, and the stakeholders have to give us a signal that we're supposed to do it. We know the disease, we know how to treat it, we know to treat it as an early stage before it has any manifestation or its true prevention. Testing is easy. We have agreed policies, European guidelines that recommend how we are supposed to treat it, and the infrastructure has to be built, and that is something we are waiting for, and that is the next step. And if that is being done, I guess we are on a perfect track. Thank you very much.
Very well done and on time. And you have mentioned, I think, 4 elements that are crucial. First of all, it is communication. Second, it is convincing. Third, it is making lobbyism with professionals, and that I think it is crucial. And also establishing something that is a good place for investment, and at the regional level seems to be that you have done. But nowadays we need to jump on, and I hope that we have him online, to what happens at the national level. We have seen that Dr. Heribert has convinced the region of Bavaria in terms of establishing the problem and establishing the program and the screening. But what about Croatia, Shaliko? How it is done at the national level, and which are the magnitudes and the issues that we can expect from a national perspective?
Okay, so after a quite long period where this was not done systematically, we decided that universal pediatric screening is a must for a country. And it was the initiative of Croatian Atherosclerosis Society and Croatian Cardiac Society, but it was supported by then Croatian Society of School and University Medicine, National Institute for Public Health, Croatian Paediatric Society, Croatian Society of Medical Biochemistry and Laboratory Medicine, and Croatian Society of Family Medicine. However, what is very important, we got strong support from Ministry of Health and from Croatian National Health Insurance System, which virtually covers almost 100% of Croatian population. So what we agreed upon and what we are starting to do is something pretty like Slovenian model. We have between preschool and primary school obligatory systematic checkups. And during these checkups, we are going to introduce for the next generation obligatory testing for FH. We are going, of course, to test lipids on the level of school medicine physician. But then we are going to direct those who are susceptible to FH to pediatricians, and also as a next step, genetic FH screening at secondary level. What is also very important, the idea is to establish a reverse cascade screening, child-parent screening. So the school medicine and GPs will inform parents on FH risk, not only of their children and their siblings, which we'll also test, but also of themselves, of their parents, of their blood relatives, and if a child has been diagnosed with FH, pediatricians are going to inform parents and recommend testing for them and for siblings, and parents and siblings are going to be referred to specialized lipid clinics, particularly the main lipid clinic, which is in Zagreb, similar like in Slovenia, where in Ljubljana is the center for the whole Slovenia. So this is how we plan to start this with next generation. Until now, it was not organized like this, but now with support of all the stakeholders, including the political level, and of course, medicine and science, we are going to start this program of universal pediatric screening for all the children.
To say that Dr. Sheliko Reiner, he's an internist and based in Croatia, and they have been successful once again. It is doable at the regional basis in a Länder in Germany. It is doable at the national level, and you can plan different type of screening programs. But my question is, what if we don't do that? Which are the consequences in terms of societal burden and economic burden? And we have Tanya Novakovic, that she's a pharmacoeconomist by training and health technology assessor, and she's based in Serbia. And they have done some programs on which are the costs and the consequences of not treating hypercholesterolemia at the national level. So Tanya, tell us.
We have been doing cost of illness analysis for Croatia, and we are conducting cost of illness analysis for Serbia at the moment for hypercholesterolemia and familiar hypercholesterolemia. And what is important to emphasize here is that the benefits, social and economic, and outcomes of the familiar hypercholesterolemia screening depends on when and to whom the screening is conducted. So we heard that familiar hypercholesterolemia patients are young patients, they are working population, they are at higher risk of cardiovascular events than the general population, so they experience their cardiovascular events much earlier than general population, and these events can be fatal, they have high morbidity, mortality, and disability. And therefore, in terms of setting the program for screening, we also have to consider that screening population can be different, because we have several definitions of the disease. We have one definition according to the genetic approach, and that means, for example, in terms of numbers, that in Serbia, if we apply epidemiological data for familiar hypercholesterolemia, there will be 30,000 patients with familiar hypercholesterolemia. But if we apply other definition, which is connected to the level of cholesterol, total and LDL cholesterol, then the patient population increase for 10 times. That's like 300,000 people in Serbia. So, going back to hypercholesterolemia and dyslipidemia, what our research shown that dyslipidemia is not perceived very often as a public health issue. And now dyslipidemia is hypercholesterolemia in general is a greater burden than diabetes. So what is the cost of not doing and cost of doing screening? Cost of doing screening will be cost of medication. We heard about statins, but probably there will be room for new medications. Also, cost of not doing the screening, is simply put, will be a failure of diet and exercise, because the first line therapy in hypercholesterolemia and familiar hypercholesterolemia, it doesn't work, diet and exercising in familiar hypercholesterolemia patient. And we heard about statins, they are not always effective. So that will be the cost. Also, the cost will be late diagnosis of atherosclerosis and the high level of LDL cholesterol cause the atherosclerosis. And atherosclerosis doesn't happen over the night. It is a developing process, so time is important, that we make diagnosis on time. And that means what I want to refer for atherosclerosis. In our research, atherosclerosis made a major cost of familial hypercholesterolemia and also hypercholesterolemia. And also, what is cost of not doing the screening is all these consequences, cardiovascular consequences, such as myocardial infarction, which is burdened not just to the patient, but to the families and the society in terms of the lost productivity, early retirement. So with the introducing of familial hypercholesterolemia screening, we can prevent these social and economic consequences.
Yeah, and more interestingly, I think, thanks Tanya, but more interestingly, one of the things that is important, that is, it will be in the future, poorer quality of life. So if you don't advance early, the consequences when you have 50 or 60, it is that the quality of life that you could have, and it is not reversed, that is the problem. So it is nice that we have still a couple of minutes for each of you. So final remarks, Albert. What if you need to convince someone, would say two, a politician? We have had with us the Vice Minister here, but we have also citizens in the room. So final remarks in terms of convincing them with good words.
Because it's a matter of time, start as early as possible. And whatever type of screening you do, but please start screening. And at a very young age, so you can prevent heart attacks and death in these children and adults as well. The good thing of universal screening and then reverse cascade is that there is an opportunity to reach all the children with FH and their parents and grandparents and brothers and sisters. But if not, there is not a moment for a blood tap somewhere between 0 and 18. Do the cascade screening when there is an index and make pedigrees over 4 or 5 generations. And you will detect what we do, 13 other cases who can be prevented.
Yeah, thanks, Albert. Very convincing. What about Heribert? And how you have convinced? Which were the words that you used in Bavaria in terms of convincing them?
Yeah, just to give you some numbers, I mean, we have this program for 1.5 years. So almost 500 pediatricians have subscribed to the program actively. We have screened more than 10,000 children. Obviously, there are many that have very high cholesterol levels. We have screened them, and we have made the diagnosis now in more than 100 families. That means it can be done, and these children have parents, of course. So the number of individuals that we identified is up to 200 already, but they also have siblings, and there's a 50% chance that they will carry the disease as well. So it can be done, and I guess the communities are waiting just for the starting signal, as I said, because it's going to be successful.
I think the figures are impressive. And what about Croatia? We have seen Celico that it was doable at the national level, but what about how you have convinced the Croatian government in terms of establishing the program, and how that experience could fit with the needs of the audience?
Actually, it was not so complicated to convince the government, because the numbers are pretty clear. What we have already heard from previous speakers, cost benefit is absolutely clear here, and so it did not need a lot of our effort to convince not only the Ministry of Health, but even more important, the National Health Insurance System, which is the payer, to spend this money, because in comparison, what is spent for treatment of myocardial infarctions, what is spent for rehabilitation and so on, this is really peanuts when you think how much you have to spend for universal screening. Of course, genetic testing is then a bit more expensive, but the numbers are uncomparable, smaller than for universal screening. So altogether, it's definitely cost effective. What I want to stress is, and what is very important, of course, it is important to discover siblings, to discover parents, to discover grandparents, uncles, aunts, and so on. But it is even more important to diagnose those children with FH who are either composed heterozygotes or homozygotes. They are very rare, of course, homozygotes, but compound heterozygotes are not so very rare, and those children are really in danger. And I can tell you an example of just one child that we have discovered before this program at the age of 3 years as a homozygote. And now he's 20 years old. He did not have heart attack. He is living normally thanks to the fact that we have discovered that he is homozygous with 3 years of age. And we have treated this child with drugs that were available, with statins first, with apheresis, PCSK9 inhibitors, of course, now, and so on. But anyhow, this child would probably die with 10 years or something like that from MI. And now he is in his 20s and he's apparently healthy.
So we have the lady with the final remarks, last minute of glory.
Yeah. Familial hypercholesterolemia population is largely undiagnosed, and they are high burden and they need urgent treatment. They are also, that we said that the time is important, and that we diagnose the disease and prevent, first of all, atherosclerosis, but then the other cardiovascular events. Introducing the familial hypercholesterolemia screening would avoid unnecessary costs, improve quality of life, and save the lives of the people.
So thank you very much to the speakers, and I think Wilson and Jungner, 54 years ago, they were right. Familial hypercholesterolemia makes sense in terms of screening. Thank you very much.
Thank you very much, Inaki, and indeed all of the panel. Fantastic session. Thank you all. This is all about looking at the science, how it can be applied to promote cardiovascular health. And it's my honour to introduce Professor Karine de Beaufort, who will moderate this session and lead it through. The floor is yours, Karine.
Nicola, thank you very much. And I would like to join the previous speakers to thank the organisers and the host. Maybe I can add, based on what we've heard before, the optimism, but mixed with a bit of impatience. Can we use science to promote and implement health measures? And how does this fit perfectly well in the EU NCD initiative to take innovative, ambitious actions to prevent leading causes of avoidable premature death? Healthier Together, how perfectly well seems FH, familial hypercholesterolemia, to fit in this. It's my honor to discuss this with four key persons in the field. Professor Hector Bueno, who is online, a clinical cardiologist and researcher, and he is an advisor to the Spanish Ministry of Health, and we heard already that they have implemented a national strategy on cardiovascular health. Professor Brian Clarence, cardiologist and genetic epidemiologist from Cambridge. Again, online, Professor Mafalda Bourbon, a biomedical scientist at the Health Promotion and NCD Prevention Department at the National Institute of Health in Portugal, and Athanasios Palladis from Greece, one of the key stakeholders as a patient advocate for rare diseases. I'm Corinne de Beaufort, current president of an international society for pediatric, adolescent and young adult diabetes. And I'm as well for Luxembourg, delegate at the Pediatric Committee at the European Medicine Agency. My big bias is I'm working a long time with NCDs and I'm a pediatrician. So I'm really looking forward to move for FH the situation forward. I've seen in childhood how important it is to go to early diagnosis and early treatment. That applies to diabetes. It applies just as much to FH. I mean, diabetes, childhood diabetes, if you don't diagnose it, it will lead automatically to an early death sentence. Without treatment, death. FH is a slow killer, but it's killing just as much. And I think a lot can be done, and certainly based on the current scientific knowledge. So here, I really would like to ask Hector, who is the advisor to the Ministry of Health in Spain on this national strategy. So what is, in your perspective, the important message from this new strategy?
Well, thank you, Corinne. I'm sorry I couldn't join you there in Prague. Well, I think this is probably the most ambitious plan ever to improve the cardiovascular health in Spanish society. And this comes from a multidisciplinary approach, but mostly through a shift in the focus. In fact, the plan is not on cardiovascular disease, but rather on cardiovascular health. When we speak about cardiovascular diseases, most of the times it's just too late. And I think familial hypercholesterolemia is a good example, particularly when they come to the hospital. Hospital-centered systems, most of our systems are hospital-centered, are too expensive. They have limited resources, and they're under increasing pressure due to the population aging, multimorbidity, dependence, and so on. And we have just experienced the overwhelming of primary care and outpatient care during the pandemic, which is still lasting. So we believe that cardiovascular health is the right approach, and we need to pay attention to the determinants of health, that is focusing on health promotion. Of course, we have our plans on cardiovascular care, particularly for the most important of them in the plan, but we have and we want to focus on the health promotion at the individual level, and that starts from childhood and education, lifestyles, the diet, physical activity, socioeconomic factors, education, regulations, food, tobacco, alcohol. So there's much that we can do, not only from the healthcare perspective, but from the social perspective. So our view, and probably the key message is here, that we have to involve all stakeholders. It's not about physicians, it's not about healthcare professionals, it's to start by citizens, I would say to start by children, educators, politicians, of course, healthcare professionals and patients as well.
Where would you see the role or the place of FH screening in this strategy? As of course, a genetic condition cannot be modified by health or lifestyle determinants?
Well, our strategy actually is cross lines between longitudinal and transversal line. So the transversal lines are health promotion, public and professional education, early detection, primary prevention, continuity of care, and so on. So actually fits very well health promotion, early detection, primary prevention. So it's one of the examples that actually fit very well this grid of this ambitious plan. That actually is a very general view that should take land in the individual approaches, as the case for familial hypercholesterolemia would fit very well our general plan.
Thank you very much. So long-term health, not disease, and it starts early, and we need to identify the different persons and treat them to render this unmodifiable condition manageable and in a certain way modifiable. Brian, we've heard now the health strategy in Spain, and when looking at current scientific evidence, because that's our mission, how can we use that to change policies? And how would the current scientific evidence improve cardiovascular health best?
Well, first of all, thank you very much for having me. It's a real pleasure to be here. FH actually represents a unique opportunity to improve the public health with science, because we know precisely what causes FH, and we have effective ways to prevent some of its consequences. As all of you know, FH is caused by a single genetic mutation that leads to very high levels of LDL cholesterol in the blood. Over time, the particles that carry the cholesterol become trapped in the artery wall, and plaque builds up gradually, leading to a very high risk of heart attack and stroke. Lowering LDL effectively reduces the risk of heart attack and stroke by preventing those particles from becoming trapped in the artery wall, slowing plaque progression. So FH is actually an exemplar of personalized medicine, because we can take that high inherited risk of cardiovascular disease and effectively reduce it by lowering LDL.
From what age onwards would you expect this LDL reduction to be cost-benefit effective? And
well, that's another opportunity to combine science with micro and macroeconomic models to substantially improve the public health. We know, for example, that persons who have FH inherit very high LDL cholesterol levels from birth and throughout life. As a result of that, they begin to develop plaque early, and it rapidly progresses, resulting in a very high lifetime risk of having a heart attack or stroke. For that reason, it's incredibly important to identify people with FH early and begin to lower their LDL as early as possible. If we now begin to incorporate the latest science about the effect of the accumulating effect of LDL on the vessel wall over time with economic models, we can now suggest, as recently demonstrated from data in Australia, that a program that universally measures LDL in children with the purpose of identifying persons with FH and treating them to lower their LDL beginning in adolescence can not only potentially reduce the lifetime risk of heart attack and stroke by 80% or more, but it's cost saving. So with FH, the message is that early detection and treatment not only saves lives, but it saves healthcare costs.
thank you. So that really shows that the early detection and normalization of LDL as a treatment outcome will be cost-effective, cost-saving, and of course, if you look at the patient outcome, something extremely important. Mafalda, as well online, health promotion and NCD prevention. We heard about the Spanish strategy. Cardiovascular health promotion should start in childhood with education and prevention, and of course, identification of the different persons who are at high risk without any lifestyle characteristics which would predict that. Normalizing LDL will predict long-term cardiovascular health, but to act now. We need to identify those persons because they don't have symptoms, and if they are not yet faced with familial disease, then we need to find them differently. Could you, maybe within a scientific picture, give us a peek in the future, and as well, what do we have to do now?
Thanks, Jane. It's a pleasure. I must say it's a pleasure to be part of this meeting. And I'm very sorry I'm not there with all of you. So scientifically, we know a lot about FH. We have more than 40 years of research on FH. So with all this knowledge, we are trying to build up a model of care, a personalized model of care for FH, where we will be able to quickly and identify FH patients at a low cost, and the genetic testing will drive the treatment, since the treatment will be based on the personal variant that each patient carries. So that's going to be the model for the near future, let's say. But for now, like you said, we need to early identify FH individuals. And there's two very cost-effective and effective, at least very effective ways. One is the one that we're talking today here. That's the pediatric screening, and that can be done very easily by a blood cholesterol test, or even with a finger prick, just with point-of-care equipment, with and a prick in the child finger, and that can easily done. And then when the cholesterol is it's seen that is high, then the child can undergo genetic testing to find the special variant, the unique variant for each patient. But the blood cholesterol would be probably the best way, because that would allow us to do a complete panel, lipid panel, and we could determine the total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. And this would allow to identify other rare dyslipidemias as well. And even we could measure glucose and all with the same sample, and then we could determine prediabetes and diabetes in children as well. So that way, that having a blood test would be the best way to do the pediatric screening. And we have to remember that the pediatric screening is the only way that will actually prevent cardiovascular disease and promote cardiovascular health, because the children would be identifying when they are young, and in time to change life habits and start treatment, and then they would never develop heart diseases when they are in adulthood. So this is actually, for me, the best way to identify FH patients. But there's also cascade screening. Cascade screening is very effective as well. It's a family study when you have an index patient, and then you study the whole family, and you can find other relatives with FH. And it's very easy, and it's, in terms of laboratory work, it's very easy, and it's very, very low cost. But that is easier when you have nurses and governmental programs like the Netherlands had, where you have nurses that can do the genetic testing for the relatives. It's really difficult for a clinician to call in all the family. So I would say that what we're talking here today is actually the best and the easiest way to identify FH children.
It is, to start with, early detection, the simple measures maybe to start with before we can move to the personalized medicine, which was already discussed as well previously. And we will be providing life-saving measures for the children and as well for the family members. But, and that's my impatience and frustration working not as long as some of you around here in this field, but still long enough to know that it's surprising we do not have universal screening in place, even not with the simple cholesterol measure. So Tanis, if I may just look to my right, based on the scientific development, the strategy on cardiovascular health, we can include the education starting early on, we can change modifiable factors, we can support healthy lifestyle, but everything just applies when we know who has the condition. People know, more than 90% in the EU do not know they have this condition. And then we have the future, which will be the personalized medicine and genetic screening. But now we need to get that simple cholesterol screening in place. And I think I'm really grateful you're on this panel, because you can share with us your experience as a stakeholder and a patient advocate.
And thank you for having me here. It is indeed a great honor for me to be representing the patient point of view in the latest developments around FH, and to utilize all this information we have, all this scientific data we have, and translate it into action. I'm mostly going to talk from a personal point of view and experience. I will leave the figures and the terminology to the ones that are more qualified than me to do so. I will start by saying that I am an homozygous patient. This is the most severe form, it usually is, of FH, and I was diagnosed earlier than most, at the age of 4, and I started receiving treatment, the first available treatments at that time, at the age of 5. And all the physicians that have been following my case throughout the years can unanimously agree, I'm pretty sure about that, that the number one factor that I am still in a very good condition at the age of 32 and I haven't undergone any surgery is because of the very early diagnosis. Of course, there are the genetic factors as well, but I mean, this is my experience, and I'm not going to talk about stuff I'm not qualified about, but definitely early diagnosis is a key factor. However, I can assure you that this is not the case for many other patients, homozygous as well as some heterozygous. As a patient advocate, I had the opportunity to speak with many fellow patients, and they shared their story about how later, like how many years later they were diagnosed at the age of 12, maybe up to 15, and it was, by that time they have already developed cardiovascular disease, and that led for them to have to go through a surgery some years after. And then, after that point, not only the quality of life is reduced, but the financial burden for the drugs they are taking, and usually people like them, they take more drugs because it's not only the lipid-lower drugs, they have to regulate their heart as well. And at that point on, they have the financial burden, especially for the drugs that are not reimbursed, and it's a burden for them and both for them and the government. Besides that, we have to realize that the job opportunities are reduced as well, because many of them, after a cardiovascular event, they cannot do physical work. And that would potentially mean more time staying in unemployment, and or even caring, needing healthcare profit for them to survive, because they cannot work. And if we take it a step even further, we can see now that it's not only about the person being diagnosed at the early age, but it's about the family and the older generations as well. Like Albert Wigman said before, if I am correct, it doesn't matter of the kind of screening as long as there is one. And then we can prevent also cardiovascular events occurring from the older generations as well. And then you would have a cost-effective, you would avoid the expenses of more and more drugs. Thank you very much.
Thank you very much, and thank you very much to all the speakers. I think it is clear from everything we've heard that it is time to act. And I think there is sufficient scientific evidence out there. There is sufficient evidence from the patient stakeholders there that we need to do something. Hector, what would be your key message to policymakers, to the European Union, maybe to implement what they have stated, healthier together, to prevent premature, avoidable cardiovascular death? What would be your key message?
I think in previous sessions it was mentioned to have an European plan on cardiovascular health. That would be my recommendation. A national or international European plan would actually be the framework to launch cost-effective and evidence-based interventions and to share good practices at the healthcare system, but also at the social or the population level. And I think that this framework actually helps to move these kind of initiatives like the one that we're discussing today. And I think that actually this facilitates very much to understand to what extent these type of interventions and these initiatives are meaningful and are helpful for the individuals, for the patients, for the society, and for the healthcare system.
Mafalda, what would be your key message?
My key message for politicians is that we have to act now. We need to start now, and we have the science with us. We have all the tests that we can do. So it's just political will. That's what we need. And like in Portugal, we even have a guideline for perform a lipid profile for every child before the age of 10. But it's a recommendation. It's not mandatory. So I think that this guideline in Portugal and other countries should become mandatory. That will make a huge difference.
Thank you. Brian?
I think the message is that it's possible to dramatically improve the health of millions of people in a focused, precise, clear way that saves costs and saves lives. And that could be most effectively done by following the science, which tells us that the effect of lowering LDL, its benefit depends not only on how low you lower LDL, but when you start and how long you continue that lowering. So I would strongly recommend they contemplate a program of early measuring of LDL beginning in childhood to identify those persons with FH and initiate LDL lowering as early as possible, and creating digital systems that can help people along the healthcare journey to make sure they're adhering to their LDL lowering medicines and protecting their arteries from FH.
Tanos.
I would just like to add that an FH screening should be implemented, but at the same time should be flexible to be in line with each country's specific policies in healthcare and specifically on FH. It should be used as a tool to identify many more patients from all generations as family members, and not be restrained for the younger generation and to be at one patient at a time. And that would be pretty much it.
Thank you. So in conclusion, I think it is clear that we should move forward, that we shouldn't wait, that it should be acting now, but with a very clear plan within at least Europe and potentially bigger, that we should evaluate best practice and implement targeted best practices in the different countries, at least within the EU, but potentially as well beyond, and that we should continue to evaluate what we are doing. We need data, but we need to start now. And to be very honest, it's good to hear that some countries, together with the music, already also have started further screening, Slovenia in the lead, The Netherlands, just as much in a different kind of lead. Luxembourg, we've got a pilot in a school screening. Croatia, Czech Republic. A lot of people, Bavaria, a lot of people are moving. But I think we now should get the avalanche effect after this meeting and get it routine, standardized, and that we don't have to come together for this, but that we have to come together to improve with new drug options or new approaches. Thank you.
Thank you very much, Karine. Beautifully moderated and beautifully summed up. And thank you to all of the panelists. Excellent. Now we're moving to a slightly different topic, health systems, constraints and opportunities as we emerge from COVID and a number of other crises that are hitting us in Europe. And it's over to Dr. Marius Gheanta, Centre of Innovation in Medicine in Romania, and also an FH Europe trustee. Thank you, Marius. The floor is yours.
Thank you so much, Nicola, for the introduction. Indeed, we'll discuss about the health system constraints and opportunities in the post-pandemic era. And yes, we discussed in the previous sessions about the science that could feed the political will, as well the economic evidence that as well can feed the political will. But at a certain point, we will rely on the health system for the pediatric FH screening implementation. Pandemic actually led the health in prime time, and health was a priority, a very high priority in Europe and worldwide for 2 years. Now with the war and the energy crisis, we see a slightly deprioritization of the health. But during the pandemic, actually the idea of prevention came forward, was for the first time when the role of the citizens from the societal point of view, from the economical point of view, as well from the medical point of view, become very, very important. And the citizens were mentioned several times today. But all the times we assess actually the health system response, the health system performance under the pressure of the pandemic. So we have the citizens who have the idea of the prevention and health system. I think are three notions clearly linked with the FH pediatric screening. As I mentioned, we rely on the health system to implement FH pediatric screening. It's not an easy task in EU. We have 27 member states, but more than 27 health systems. And there is a challenge indeed. For this, we'll have a crucial, I think, conversation today with as well another great lineup of speakers. And it's my pleasure to announce that we'll be joined online by Professor Fausto Pinto, is the president of the World Heart Federation. As well online will be Dirk van den Steen from the European Commission, from DG Santé. Dirk is in charge with the health system, and his perspective is very, very important in this context. As well, we are joined by Professor Mariana Abifadel from St. Joseph University of Beirut in Lebanon, and as well from INSERM in France, but that is, in fact, is the discoverer of the PCSK9. And so we have the PCSK9 guru with us, as well we have the health economic guru with us, Iñaki Gutierrez Ibarluzea, and as well the digital guru with us, Dr. Andrej Majek from Institute of Health Information and Statistics from Czech Republic. So this is the lineup of the speakers, and I would like to address to all of you the first questions that is about the lessons learned in the context of the pandemic that can inform maybe as well the FH pediatric screening. And I will start with you, Professor Fausto Pinto, to answer first.
Well, thank you so much. It's really a privilege to be among such a
a distinguished group, and on behalf of the World Heart Federation, I really want to thank this opportunity. It's been a great discussion, a great meeting. And regarding your specific question, what I would say is, first of all, as you mentioned, all the health systems have been subject to an extra strain with the pandemic. And actually, if anything, it showed the frailties also of different health systems across the world. But what was also clear was that particularly the NCDs, the non-communicable diseases, were the ones that were, on one hand, more affected, and particularly cardiovascular diseases. As you know, patients with cardiovascular diseases, they have a higher chance of getting infected, and also when they got infected, they had a higher chance of developing more complications. So one of the key elements we understood is the need to have a better control of NCDs, and of course, in this specific case, FH and hypercholesterolemia and dyslipidemia as a whole plays a central role. And this is actually part of a lot of discussions and a lot of important documents that are being produced either by WHO, and also we produced a recent roadmap on digital health, which is an important element that also was very relevant during this pandemic. And we'll be presenting very soon a roadmap also on cholesterol, which will focus different elements related with the importance of having, specifically regarding cholesterol, having it as a very important area to tackle, particularly when we talk about NCDs and we talk about exactly what it meant in this specific pandemic. So I will summarize by saying that one of the lessons that we certainly learned with this pandemic was the need to have better NCD control, better control of conditions that can actually have a major impact, I would say, in any potentially new pandemic or new area that can happen in the future, and therefore the need to have strategies to tackle that, to combat that, and to be better prepared in the future for pandemics or any other sorts of diseases or catastrophes that can happen to humankind. So better NCD control, certainly one of the big lessons that we learned with this pandemic.
Indeed, a better control of the NCDs is a key message, and especially in the context of our focus as health system and medical professionals in the last decade, actually on the NCDs. And I know that the pandemic was a challenge as well for the European Commission, that overnight actually was in the position to act and to guide as well some member states. So I'm going to you, Dirk, and asking your perspective. What are the lessons learned from pandemic at the European Commission level?
So thank you, Mr. Moderator. It's a pleasure to be on the panel. You asked about lessons learned. Well, exactly on early lessons learned, last year already, the Commission put forward a communication, early lessons from the COVID-19 pandemic. And there was one lesson in particular, lesson 8, which deals with the health systems. And as we all know, what we saw after the onset of COVID-19 was that a lot of pre-existing structural weaknesses in health systems were really put to the stress. And that's the main lesson. There is a need to continuously invest in the resilience of health systems, and that goes beyond public health capacities. We have established, for instance, a health emergency response authority also in response to COVID-19. But we also saw, for instance, that a lot of the routine care in health systems was disrupted. And that is also chronic disease patients mainly. So there really is a continuous need for a structural across the board investment in health systems to maintain this resilience. Now, at the time last year, the focus was on having member states use the Recovery and Resilience Facility money. This is a facility, a fund that that puts around 720 billion to the disposal of member states to invest into reforms and other measures. Now, just last Friday, we brought out, the Commission, a new communication on the autumn-winter forecast or preparation, also related to COVID-19. And in there's a little state of play on what we have done in the meantime, we, meaning the member states, together with the Commission. So if we look at the recovery and resilience plans, we see that already over 40 billion, more than 42 in fact billion, are earmarked for investments, new investments into healthcare. And this is for 25 plans. We don't have all 27 in yet. So that's important. And again, we repeat the message. We repeated the message also last Friday, that there is a continuous effort needed. It does not start and stop with the recovery and resilience facility. It is not only about communicable diseases and public health capacities, but certainly also about non-communicable diseases, prevention across the board, workforce availability. And these same messages we also repeated in June when we put forward to 8 member states country-specific recommendations on the European semester. And if you look at the recommendations, you see we stress also prevention, primary healthcare, and workforce shortages. Thank you very much.
Thank you, and it was very good to see that a lot of member states actually put in the recovery and resilience facility plans for health, including for screening and prevention. So thank you so much for your insights coming from European Commission. And now we are moving to Marianne.
Thank you. I would like to thank the organizer for the invitation to this very interesting and important meeting. COVID has learned us many lessons. First of all, I think it's the necessity of promoting health and prevention to all. The second is the power of science and the power of diagnosis, and especially molecular diagnosis. And also that there are no boundaries between communicable diseases and non-communicable diseases, and that patients with cardiovascular diseases are vulnerable. And we have to fight and reduce all the risk factors, and familial hypercholesterolemia and high cholesterol levels are risk factors for atherosclerosis, cardiovascular diseases. And it reveals also the importance of collaboration between all the actors, the patients, their families, the physicians, the pediatricians, the policymakers, and all the healthcare professionals. It is the key of success in fighting familial hypercholesterolemia as well. For the implementation of the diagnosis at an early age to be able to prevent cardiovascular diseases, for research as well, and for managing the disease. Look, I think this is all lessons from COVID that could be also important for FH.
The power of science, indeed, and the power of diagnosis, and as well a keyword is collaboration. And I think the collaboration was highlighted during the day in relation with the FH Paediatric Screening. Iñaki.
Let's be a little bit provocative. So why we were in the stage that we were? First of all, the way of thinking of the healthcare system. We were not talking about which the client is. The client is the citizen. And we have been talking about healthcare systems from the point of view of healthcare system and not from the point of view of the society. If we go to which are the main drivers of budget, it is half the budget of a healthcare system, it is paying the professionals. 1/3 is drug expenditure. And the other part of the budget, it is the rest. So what happened when COVID-19 started? We were talking about sustainability. And those that we are informing in terms of sustainability for the systems, that we are the HTA bodies, we were concentrated on drugs, how to organize best the healthcare system, and medical devices. What about prevention? It was not in our umbrella. It was not under our portfolio. We were concentrated in single technologies and not in interventions. What happened with the sustainability of the systems? Well, it occurred that something happened. We were not concentrated in high-income countries on communicable diseases, but it came communicable diseases. And seems to be that the systems were not sustainable. But huge amount of money came to the systems in terms of solving the problem with COVID. So it is not a problem of the healthcare systems. It is a problem of how to establish priorities. Someone, and there were many politicians that were saying, there is no economy without health, and there is no health without economy, and they are right. Nowadays, we have prevention in the portfolio because we have seen that without health, economy is not running, and without economy, health is not running. So we need to establish other type of priorities in terms of going that. Same as happened this summer. We have had an unexpected hot season in all Europe. And we have seen that we have had fires in many of our forests. Why those happen? It is because of climate change? No, it is because of not prevention. Because we were not taking care of our forests, they were not sufficiently cleaned, and that's why fires started. And there was not investment in prevention. So, things that we can learn from the future. It is, if we go for prevention, we will save money. If we go for the systems, the budgets are coped already. So if we wanted to establish new programs, and we wanted to maintain the economy, probably one of the things that we need to do, it is to think about prevention, to think about which our priorities are, and probably we will save money. Thank you.
And in order to establish priorities, in order to set the priorities, we should ask the citizen, and we also need very good data. So I'm going to you, Andre. What are the lessons learned from your perspective?
Yeah, thank you very much. Actually, to me, the most important lesson probably is that we actually can and probably must work together as European Health Union. It was probably unthinkable not so long time ago, but currently we are really acknowledging from examples like common development and procurement and distribution of vaccines, but also other interesting pieces of health policy are actually coming from the European Union. And already today we have heard about the Europe's Beating Cancer Plan, and I think that's a really interesting and complex piece of health policy. I would like to recall one particular part that is actually dealing with cancer screening, and I've been working on cancer screening, so that's example quite close to my heart. And I think also the Europe's Beating Cancer Plan, but the activities also in past represent really good example how we could approach looking for inequalities in European Union, finding solutions, then finding consensus, and then really looking after that the convergence is really happening. So that's more like international example. I think a good national example is actually how in the face of health threat that COVID posed, we were actually able to quite quickly adapt and do some changes, for example, in digital health that previously, again, were sort of unthinkable, and it was able to make it happen quite quickly. And I think those are examples that we can really also be inspired by when fighting another health threat, which is the FH. Yeah.
Thanks. Thank you, Andre. I think so far we have been quite good in diagnosing the health system. And now we are moving in the second part of this panel to the treatment. And yes, this precise diagnosis could be followed by a precise treatment. In other words, what are the incentives to better implement screening programs or to start implementing the screening programs? And I will keep the same order and ask Professor Fausto Pinto to ask this question.
Well, thank you so much. And it's clear, and actually the previous colleagues already mentioned, all of us, the importance of prevention and the importance of including here FH screening and FH screening from an early age, and that's something that has been discussed for some time, as very relevant to identify the people, the patients that will need early treatment. And if we can do early detection and early treatment of this population, we're actually doing, in a way, a modulation of the natural history of this condition. And therefore, this should be seen as an investment and not as a cost. Actually, the way I see it and the way many of us see it is all these things that should be seen as an investment and not as a cost for the health systems. But let me tell you also, and that was briefly mentioned, the importance of having a European plan for cardiovascular health. There is for cancer, fantastic, but there is not for cardiovascular health. Let's keep in mind that, and I just remind that cardiovascular diseases still represent the #1 cause of mortality and morbidity at the global level, including in Europe. Therefore, there is a clear need, but many of these things should be included, of a cardiovascular health plan for Europe. And that's something that a meeting like this should also have as a recommendation, because we need that. But just focusing on your specific question, I would say, to start the discussion, that to be a big promoter of early FH screening can have a major impact, particularly by identifying the patients, the people that will need early treatment, and therefore changing totally the natural history of these people. Thank you.
Thank you, and thank you for highlighting again this idea of cardiovascular health plan for Europe, mirroring the European Bureau's Beating Cancer plan. And indeed, this is a challenge for you, Dirk. I know that Commission already is working on this. The Healthier Together initiative was already highlighted today. What can you add in addition?
Yes, thank you, Mr. Moderator. So as you mentioned, the direct support, if you want, coming from the EU level would indeed come from the non-communicable diseases initiative, Healthier Together. And already in the past, and I also read it in the declaration, we had, of course, exercises, and as a result, we have pediatric FH screening as a best practice in the best practices portal. And there are further ongoing discussions with member states and experts, and this is the Europe and the EU as a forum for exchange of best practices. There are further discussions in coming days with member state experts, including on this particular best practice. And for sure, if we look a bit further, what could be the outcome of such discussions under the 2022 work program of the EU for Health program, there are, of course, potentially funds available for supporting member states to step up more ambitious action in this field. So that is from the EU level, which basically at the end of the day, it is about having member states work together and then agreeing on best practices and agreeing on ways of trying to scale them up in Europe. If I think a bit more broadly, and we think about incentives, then I would like to raise the example of some of the discussions that are ongoing in the context of the pharmaceutical strategy. Again, of course, with member states, with the authorities that are responsible for pricing and reimbursement. This is non-legislative work, but there have been a series of meetings which are very interesting, discussing novel payment methods. And a lot of the discussion, of course, is about how to properly evaluate prevention and lifelong benefits. And this goes beyond medicines. It starts with the diagnostic. And more generally, it is also about primary prevention, if you like, as an intervention for our health systems. So I would leave it at those two examples, but I think they're pretty striking. Thank you.
Thank you.
I think we need a better education of all the citizens, of the patients, but also the professionals and the policymakers about FH, about the disease, about the burden of the cardiovascular complication, and of course about the early prevention and early screening. And I think it is, people should know that It is genetic and familial disease, but it is an actionable disease, an actionable, medically actionable state. And we can diagnose it. If we screen it early and diagnose it, we can manage the disease and we can treat it. We have the tools, easy tools for diagnosis, easy tools also for treatment, and at least efficacious tools. So we have no excuses anymore. And I think it would be a message of hope from Europe to save the life of next generations. And I think also that other part of the world, especially the poorest, will need this example. And it's something that many countries are waiting for, with equity.
Yes, indeed, the role of education is a key, and in particular, I'm happy that you raised this idea that we should educate actually all the stakeholders, including the healthcare professionals. You mentioned that the FH is linked, of course, with the genetic disease. It's very good to know that it's actionable, as you said. So the healthcare professional, the primary care professionals, cardiologists, pediatricians, and so on, should be aware that they could easily diagnose, and there are preventive solutions for this. So thank you once again for highlighting this topic of education. Iñaki.
Well, Dr. Fausto was saying that we are talking about cost, and I think he's right. What we are doing in systems, it is creating cost. And we will go for investment when we start preventative measures, because it is something that you put money in terms of having results at the long term. So that is one of the things. The second thing, it is not knocking the door of the healthcare systems and blaming on healthcare systems in terms of sustainability. Because if the benefit will be for the society, we need to have other type of ways of investing in health. And the money should come not from the healthcare system, but probably from other parts of the society that will benefit from that, including industry and some others. And another thing that could be, I think it is the Commission is doing something in this regard, at least trying to explore new ways of investing on health. And we are involved nowadays in a Horizon 2020 program that is how to try to invest money in preventative measures and public health interventions in general, and which is from where the money should come. And I don't think it should come from the healthcare system. And another thing that it will be also important, it is changing the way of coding. Up to now we are using interventions, but we are not coding as interventions in healthcare systems. WHO is nowadays doing a huge effort in using new coding, not just to put a tag and say you have this diagnosis, not just saying that we are going to pay for diagnosis, that is the DRJ system, but paying for interventions. And for that we need a coding systems that identify interventions in which we include diagnosis, the treatment, and the follow-up. And in this sense, paying for interventions instead of going for single interventions that we are doing within. So it will be in some cases we have a struggle because we pay for the diagnosis, but we don't pay for the intervention. If we talk about overall interventions to treat a problem, probably that will change also dramatically the way that we are going to approach to investment.
Thank you. Andre.
Thank you. I think we are now at the point where we should actually, and we started actually to do that, I think with all the materials and all the efforts that were done in putting this very conference together, I think we are on a very right way. And what we should do is actually putting the evidence together, putting the good practice together, putting the opinions together, and then really create evidence products that would answer questions of different stakeholders, being it patients, being it politicians, health professionals, healthcare payers, in different contexts, because of course contexts may matter. But maybe we do not have perfect answers to all the questions that may arise. But likely we are now at the point where we could start implementing these programs in a controlled environments, and maybe it's a good time to actually learn more by doing that and maybe save some lives along. Yep.
Thank you. I think we can conclude that from the health system perspective, when it comes to FH pediatric screening, we need new models. And the new models in terms of new design, and I will refer a bit on these new models in terms of pricing and reimbursement. And Iñaki highlighted this idea of paying for the whole course, not for just a single intervention, but for everything. It's very important to raise again this idea of collaboration and co-creation, and this is very important when it comes to citizen engagement. And I think one of the messages is, in order to become more efficient for prevention in general, we should slightly move beyond the traditional health system and beyond the traditional stakeholders that are part of the health system, and to move to the society. Of course, for this, we need new tools maybe, or tools that are already available but that we are not aware of because we didn't look beyond the health system. And we should be very clear that when it comes to citizen engagement, the issue of trust, it's a very important one. And I think the trust issue was one of the key lessons of the pandemic. And I think this is as well the link to the next session. And back to you, Nicola. And thank you, all the panelists.
Thank you, Maris. Thank you to all of the panelists. That was a fantastic segue to indeed the last panel of today, which I have the pleasure and honour of moderating. This session is actually focusing specifically on this crucial issue of public trust and behaviour. We have three outstanding professionals here with us today, Thomas, Milka, Bledin. And while I rush around the corner here to get into my moderating position, I would like to invite you to introduce yourselves and perhaps share one big thought that preoccupies you when you're thinking about building public trust and behaviour. And if I can ask you to be as brief as possible on this, because I've got a few other questions up my sleeve. And let's kick off with Thomas, please.
Okay, hello everybody. I'm a pediatrician and geneticist, and I'm focused on the molecular genetic background of familial hypercholesterolemia. And my work has been dedicated to FH since 1998, when I participated in the WHO meeting in Geneva, based on which the report on FH was published. And when I came back, I founded and have become responsible for the Czech MedPed project. And MedPed is an acronym for Make Early Diagnosis to Prevent Early Death, which is guaranteed by the Czech Atherosclerosis Society. And I'm also a member of the FH Europe Scientific Advisory Committee. And my idea, which I would like to share with you, is that trust is really crucial. And if all stakeholders trust that individuals with FH can live with the same risk of heart attack and premature death as people without FH, we will make it. All the FH patients just need to be diagnosed and treated early enough.
Thank you, Thomas. Milka, to you, please.
Thank you, Nicola. Is it on? Yes. Well, let me start by saying that I sit here before you today on behalf of EFA, which is the European Public Health Alliance, which is the leading public health NGO in Europe, advocating at the European level on a broad range of public health topics, including the likes of NCDs and health inequalities. We bring together more than 80 organizations from across Europe, from the EU umbrella organizations to the tiniest of grassroots. We also bring together a very versatile group of members from healthcare professionals, research organizations, patient organizations, but also those that represent the interest of vulnerable population groups. What sets us apart is that we are a people's public health organization. Very shortly, my own background is a combination of scientific research and academic teaching in the areas of NCD and atherosclerosis, but also science communication and policy and advocacy work that makes me really excited about the importance of today's event and of the Prague Declaration. As of the topic of the panel, I don't think I will exaggerate if I say that never in our history have we been more exposed to more knowledge and information. And equally, never was our behavior so influenced by a lack of awareness, by misinformation, and by distrust. And I would state here that to earn trust and influence behavior, science is not enough, and the competence won't cut it. It takes persistence and honesty and reliability, and it also takes listening before talking. Thank you.
Thank you very much, Milka, and wonderful to have you with us, obviously. Over to Bledin, please. The floor is yours.
So thank you all very much for attending. I'm delighted to thank FH Europe for organising this event and for the Czech presidency for its leadership. So I'm an international healthcare lawyer, and despite that, I'm a good guy. So I have experience in Europe, the Middle East, the US. I spent 4 years seconded to the UK Department of Health in a team that's quite notorious, that worked not for the Department of Health, but for the British Prime Minister, as he was trying to reform the NHS. So I'm chair of the Digital Health Society, deputy chair of the European Connected Health Alliance. The European Connected Health Alliance has 70 international ecosystems taking best practice, lessons learned, failure from one place to another. We don't recognize borders, and we're trying to improve services, outcomes, and systems sustainability. Ecosystems are regional, so they're geography-based, and they try to involve all stakeholders needed to transform health and care systems. So my big observation, and I like cheating, as you're about to find, is I have two. So the first one is innovation moves at the speed of trust. And the second one is healthcare knows no borders. Thank you.
Thank you very much, Bledin. So a question, I think, to all of you. We've heard during the course of today that FH Paediatric screening is a public health issue. 90% of people across Europe, across the globe, are not aware of living with the condition. So how can that really be tackled? And I'd like to go back immediately to you, Bledin, because I know you have some interesting thoughts about ecosystem, but I would also like you not to cheat and be very brief, please.
So I think the contribution that digital has to make is about communication campaigns to inform and raise awareness. And obviously, social media is a variety of platforms, recognizing that there's a difference between the generations as to which platforms people like. But using that as a tool is very important. And then I think attending, in particular, digital conferences to convey the messages and the information that you've been talking about all this afternoon is critical. I think it's innovating with information, so that in terms of screening, I'd like to see you think out of the box. So how are you going to screen? You talked about schools, I'd be talking about sports clubs. So for cardiovascular disease, many of the sports clubs in the United Kingdom have started screening on match days their supporters. And not only are they screening older white middle-aged men like me, who are difficult and hard to get to, but they're also capturing the young children, which is obviously one of your focuses today. I think then linking registries and screening with EHRs and making sure that information is understood across the whole of the continuum of care is important. And then I think data has a big part to play in health data screening, understanding the hotspots, understanding the success of campaigns, both for information and for screening itself.
Thank you, Bledin. Thank you. Milka, again, the European Public Health Alliance, vast experience in supporting public information campaigns across Europe. A lot has been learned over the years. What's your comment on this?
Well, I think in this field we find ourselves in an awkward situation where the science is there, the treatment is simple, the benefits are clear, including the cost effectiveness. The barriers seem to be removed, and still we are lacking awareness. So what I think we need here, in order to reach a full-blown universal implementation of early FH screening, is persistent, repetitive information campaigns. And not only for the general public. I think we need to inform and educate everyone, and Marianne was referring to that. We need to educate patients and citizens, find, for instance, women as carers or children as key target audience, but also inform educators and healthcare professionals and policymakers. And in doing so, we need to be aware that each of these target groups has their own communication needs. And each of our communication campaigns need to be adjusted in the value, in tone, in channels to different audiences. And also we need to be clear and offer really simple and actionable messages. And having listened to this discussion today, I realize it takes an FH professional to understand some part of our discussions here. I think we need to move away from our geeky jargon and talk simple, speak the language that different groups will understand. And I think also in order to make sure that we are heard, we have to make sure that we are listening. I think we need to be where the discussion happens. And sorry, Bledin was referring to social media. It happens there, among others. We need to talk with people and not at people. We need to listen to people's concerns. And even if we don't deem them so, they tend to be legitimate and answer to those concerns. And we shouldn't be shying away from emotions. And finally, I think it's also important for these communication campaigns to co-create them with those that we want to reach. And I think also alignment among stakeholders is important so that we can produce consistent messages, and persistence is critical. So we have to repeat again and again.
Persistence, reinforcement, repetition, indeed. I think we have a lot to learn from the European public health community. Thank you very much, Milka. Over to you, Tom. So how do you see it through the lens of the Czech Republic?
I'm asked about how we stand with FH in Czech Republic. So don't throw stones on me because Professor Vrablik has already talked about this. So if I repeat some figures and facts, so I think Czech Republic is well performing in terms of FH diagnostics. I even can proudly say that we belong to the best performing countries if we look at the relative number of patients diagnosed with FH. And I have already mentioned the MedPed project, which is running for more than 20 years here. And we have established a network of 66 lipid centers all around the country. And we have registered more than 9,000 FH patients, which is roughly 25% of all FH patients who are expected to live in the Czech Republic. Well, it's good, but it still means that there are 75% of FH patients who remain undiagnosed. Well, the Netherlands is very exceptional. They have more than 70% FH patients diagnosed, but I think our figures still are good compared to other countries. And of course, children are included in this. numbers, and they are identified by different strategies. And one strategy is a selective screening, which is mandatory at 5 and 13 years of age in those with a positive familial history of a premature cardiovascular event. And other strategies are opportunistic screening and cascade testing in families with known FH. But it has been shown that selective screening is not sensitive and specific enough, and it calls for changing the approach. And the universal screening seems to be very promising, as it has a big potential to improve the diagnostic rate dramatically. Currently, there is a pilot project of the universal screening in neonates running in the Czech Republic, and we intend to find out if this strategy can be efficient and suitable for a Czech healthcare environment.
Thank you, Thomas. And it's clear that the level of collaboration across the Czech Republic, not only in Prague and the 66 centres across the country, is an important factor. So taking a different angle, and I would really ask you to be really brief on this question, because I then want to move on the key question of trust. How can we better support patients and citizens at different stages of the life course? We've heard mention made of the life course and how critical it is to target individuals at the right time with perhaps different needs. But I'd love your comments on that. And Milka, perhaps you could kick off.
Well, as childhood is where it starts, I would like to start by reminding us that every child has the right to the highest attainable standard of health, regardless their sex, race, socioeconomic status. This is enshrined in the international law, and all EU member states have undersigned the UN Convention of the Right of the Child, and hence have the obligation to ensure that children enjoy this right. Now, this right includes reducing child mortality, it includes preventative and primary health care, and it includes the right to access education and knowledge. And I think we have mentioned it all today. So it's our duty to deliver on this. And applying to the FH and thinking of the first 1,000 days of a child's life, as Athanasios was saying, finding it out if a child requires attention earlier rather than later makes a difference to people's quality of life, or makes a difference between life and death. So it's our duty, we have no excuses. And I would like to call your attention to 2 points. One is child participation in this process, and the other is health inequalities. On child participation, I would like to say that public policy developments often, not to say always, are for adults, by adults. And there are services that primarily target children, and still they're hardly ever designed with children. So that's what I would like to call us all to consider this participatory approach to awareness raising. And the second is that the children from disadvantaged groups often do not see their rights fulfilled. So I would stop there, and I would just like to say that the Czech presidency has a chance actually to put the need for a systemic FH screening in children, especially in vulnerable groups, to the agenda.
Excellent, thank you very much. So Bledin, what's your take on this?
So 4 quick points. So one is health literacy and the need to have health literacy, health care on the school curricula, to teach children about wellness, awareness of specific risks to themselves and to their parents and to their grandparents. You need to see children not as patients, but as effectively the ambassadors, the link to training their parents, training their grandparents. The link between grandparents and children is very strong, stronger than it is in many ways with parents. You need to tap into it. Secondly, digital health libraries. So in the school curricula, where do you get the materials from? You can get incredible material from sports, professional sports clubs. So in my home country, Wales, the national sport is rugby, and the Welsh Rugby Union used their nutritionists to create content for schools to teach the children about healthy eating. More interestingly, when I first met people in the Welsh Rugby Union who were doing this, I said, what are you doing in schools? And they said, we're in schools, but not in tracksuits. And I just thought that's really clever. And then thirdly, I'd be developing information apps that can be a trusted source of information to all of the groups that we're talking about. And fourthly, here's a bit punchy, okay? You need to stop being so polite. I've listened today to you talking about 54 years, the first evidence coming out, then 20 years, and then somebody else saying 30 years. As a lawyer, I'm thinking, what the hell have the countries been doing when they're sitting on these evidence and people have been dying? It feels to me criminal. It feels like it should be a scandal, okay? So stop being so nice, shout louder, demand change, do not accept political procrastination, excuses, change. Thank you.
Thanks, Bledin. I think from the sound we've got in the room that everybody agrees with you and has to sort of do a little bit of a change in mindset, perhaps. So now let's look at another very thorny issue, public trust. Let's probe a little deeper. We don't have much time, but I'd like to hear from each of you what you see as being a core component and why does it matter in FH paediatric screening. I'd love to kick off with you, Thomas.
Okay, and it's clear that there are many levels of trust which is necessary, and each component is very crucial. This is the trust of healthcare professionals, mainly pediatric primary care physicians, to perform screening. But we need not only to convince them about the necessity of early FH diagnosis, but we also have to ensure sufficient capacities, realistic logistics, sufficient number of pediatric centers which could be coupled with adult centers. Their administrative burden has to be lowered because they justly feel overloaded. And another important point, we have to provide them with high-level guidelines which say not only how to deal with FH children, but also how to deal with non-FH hypercholesterolemia and other types of dyslipidemia, which will be diagnosed alongside FH. We need the trust of politicians and decision makers and high-level officials in health insurance companies to ensure a supportive environment, including the resources. We need the trust of public to collaborate in FH screening and to collaborate in cascade testing in families. We need the trust of FH patients to adhere to treatment. Again, we have to ensure that a positive diagnosis of FH will have no impact on their position among mates in their classes, in their employment, no impact on their health insurance, no impact on the approach to other healthcare, etc.
Really important points, thank you. Bledin, to you.
Thank you. Right. So I believe there are four key components of trust. So one, knowledge, information, and awareness about the condition, the benefits of screening, treatment options if needed, and potential outcomes, and any risks that the screening or treatment may have. Two, clear communication at every step or stage. Nothing about me without me. Transparency. Some of these things are easy to say, not so easy to implement, I recognize that. Action after screening. I'm told the results. I receive treatment. Something, for God's sake, happens. It doesn't just end there and I know no more. 3, honesty, understanding, compassion, and patience. Easy to say. Think in terms of risk and benefits, and then apply that. Also think in terms of, how do you judge who your friends are? Do you trust them? If you apply that same approach to how you treat your social interactions with what we're talking about, you start to get it. 4, distinguish between trust in who and by who. Think about the perspectives of patients, the perspectives of families and carers, the perspectives of healthcare professionals, the perspective of regulators, system, and payers. This is not a one-size-fits-all or a one approach. It needs to flex to recognize the different interests and challenges and problems that each of those groups face. Thank you.
Thank you, Bledin. Your 4 points on each question, that's fantastic. Very clear. Milka, last word goes to you, please.
Thank you, Nicola. I think I may lift it up to a bit more general level. Well, Tomáš was opening his intervention today by saying that trust is key, and I agree, trust is the key to positive relationships, and it is central to how we interact with each other and how we behave. And trust becomes even more critical in the times of crisis, whether that crisis is on a populational level, and we saw that with COVID-19, we have just learned the lessons from there. We see it with the war in Ukraine, we see it with the climate crisis, but also when we face individual challenges. And raising a child is already a challenge on its own, but facing ill health is as well. What happens is that we are witnessing a plummeting trust in all core institutions of society, in government, in media, in NGOs, in industry. What concerns me most is the declining trust in science. That has to do with the evolutionary nature of science, of course, which makes it exceptionally difficult to communicate and to translate the evidence into policy and practice. But I really think we must not be discouraged, and we must persist. And when I say we, I mean every single stakeholder or every single actor in public health landscape, from policymakers over private sector to civil society. So we must keep translating science into our policies and interventions in a collaborative manner. And I would like to close with what I opened. We must do so by focusing on co-benefits rather than on trade-offs, and each of us need to carry our own competence, honesty, and reliability as our badge of honor. Thank you.
Thank you very much. Some really, really powerful messages from this last intervention, but throughout the course of the panel. And picking up on a few comments, science isn't the answer alone. We need targeted information and communication that meets people at the level that they are. Innovation really moves at the pace of trust. Obviously, digital transformation, data, health literacy is absolutely critical. We need actionable messages. We need to look and keep an eye on our jargon and make sure that we are understandable and accessible. We need to think about how the Czech Republic has made so much progress with the collaboration and the networking that's happening there, and the innovative pilot projects that are happening. The importance of a rights-based approach and enshrining this in everything that we do, leaving no child behind. It's really a duty for us to deliver. Not talking at people, but with people, notably around child participation, keeping an eye on health inequalities, intergenerational solidarity. I think we all heard Bledin's plea to stop being polite and patient and procrastinating, the importance of infrastructure and making sure that everybody is on board and the burden for the different players concerned is acceptable, if you like, and looking at aspects around transparency, honesty, compassion, and taking on board different perspectives and respecting those, I think, is really important, and listening was also a really key message. So thank you all very, very much. I really enjoyed this session, and I'm sure all of you have. And we now move, I think, to the last session, where we'll be exploring the Prague Declaration, and you've heard quite a bit about this already. But now I would like to invite Kristina Chilikova to come to the floor and to just unpack the Prague Declaration for all of us and highlight the key points. Kristina, the floor is yours.
Thank you, Nicola. Ladies and gentlemen, as one of the organizers of this event, I would like to express many thanks to all of you for this afternoon very thoughtful and fruitful discussion, which has brought us further in our quest for FH pediatric screening in Europe. With this in mind, we prepared the Prague Declaration, which outlines our key asks moving forward and reflects the spirit of the important sessions we have held today. I know you have all seen the declaration in your drafts, but just as a recap, in brief, we are asking for political leadership and commitment to make pediatric FH screening a reality in all EU countries, and investment and a policy framework to raise awareness of FH and its rare form among healthcare professionals and the public to build trust and acceptance. Also, we are asking for comprehensive programs for early detection, screening, diagnosis and treatment of FH and homozygous FH across the life course in every country. We are asking for specific measures to promote the widespread use of screening programs and follow-up treatment for both forms of FH. We are asking for targeted research and development in the field of FH and homozygous FH. We are asking for capacity building of healthcare professionals and empowerment of patient communities. And finally, we are asking for commitment to knowledge sharing and monitoring through international exchange and benchmarking within and outside the European Union. The declaration draws on the key documents and milestones to date, from the work of WHO over 20 years ago, through to the high-level technical meeting under the Slovenian EU presidency in October last year. It also reflects a new dynamism around prevention and cardiovascular health rather than disease. Before giving the floor to Magda Dacord, I would like to underline that our organization, Diagnoza FH, will be using the declaration as a basis for the very constructive discussions with the Czech government and fellow stakeholders to build on existing work here, driven by Professor Michal Vrablík and Thomas Freiberger and many others, and our very close collaboration with FH Europe and the fantastic network of strong partners, because together we are stronger. Thank you.
Ladies and gentlemen, forgive me for being a little bit controversial. You might imagine I have slightly changed my final speech. FH pediatric screening is not about finding patients, but it's about finding children early so we can help them manage their condition and live fulfilling life. If we're talking about patients we failed, I would like you to remember that, because we're on a mission to promote cardiovascular health and not disease. So thank you, Christina. I would like now to take a moment to pause and to thank you. I would like to thank the Czech FH Patients and People's Organization, Professor Vrablik, Michał, Professor Freiberger, all your Czech colleagues and everyone who has been involved in today's meeting. I would like to thank the organizers. I would like to thank the moderators, the speakers who made their way to come to Prague and to make this landmark event happen. Thank you to the participants here in the Senate building and those of you joining from around the world online. We truly are grateful for your support and engagement, which will be the key to implementing pediatric screening in your respective countries. Back to the declaration. Back to the declaration, which was the brilliant idea of Dr. Iñaki Gutiérrez Ibarroleza. So a special shout out goes to him. Iñaki. And indeed to Dr. Marius Janta, the FH Europe's trustee, who was also a key architect of today's high-level political event. As you have heard from Christina, the Prague Declaration has captured our key asks, and we are committed to making sure that this important document reaches many policymakers and decision makers, as many as possible. But we need you. We need your help. We need your help to make pediatric screening reality, and ultimately to save lives and to protect cardiovascular health of our future generations. So with that, I would like to invite you to do 3, not 4, 3 things. First of all, for those of you present here, demonstrate your commitment by signing a symbolic declaration after this meeting. After this meeting closes, in just a few minutes, you will be able to grab a pen and write your signature on this massive wall. Dr. Kraus, have the honor of being first. We will take some pictures. Second, please do disseminate the Prague Declaration as widely as possible to your networks, inviting them to share it even further and endorse it, to raise awareness and to demonstrate the wave of individual, organizational, and political support. And thirdly, crucially, share it with the policymakers and decision makers you know, and invite their endorsement. We have already achieved endorsement from almost 30 international organizations, a great foundation to build on. FH Europe will be in touch with you in the next few days to help you follow up. Thank you so much for your continued commitment. I am convinced success is around the corner, but we need to continue to build on the momentum of today and reach even more leaders in the position to decide on the future of children and adults living with FH, both forms. With this said, allow me to give the floor to Dr. Kraus, member of the Czech Senate responsible for health policy, As I do this, I would like to thank you for your generously hosting this meeting and for the unwavering support you have demonstrated to our goal of making FH Paediatric Screening a reality in Europe, and who knows, maybe even beyond, with fantastic support. Czech Republic is paving the way for the other countries and other governments. Dziękuję.
Ladies and gentlemen, thank you very much for giving me the opportunity to say these closing remarks at the end of our today's conference. Being here and listening to all these interesting discussions was great. I was able to follow most of it. Apologies for the moments I could not be here. I am very happy to see that the Prague Declaration has its space on the agenda. It has been repeated many times. It's a great document, very well prepared, and it will serve as a basis for other meetings and conferences which will be taking place after our today's conference. I'm very happy the document has been supported formally by Mr. Válek, the Czech Minister of Health, and also by the Vice Minister Dvořáček, who unfortunately cannot be here right now, but he was here to open the session. Personally, I would like to say that I fully support the Prague Declaration. Like I have also already said, we will organize an informative briefing for our health committee of the Chamber of Deputies and of the Senate, and then there will be a roundtable organized. We will discuss the individual specific steps of implementation of fighting FH in children, because there is no time to wait. We need a specific program, a specific plan to implement the screening. Our goal number 2 is to start immediately negotiations with health insurance companies, so they are willing to pay all these screenings. We've already mentioned all the benefits and also their impact on the health of the children, but also the socio-economic impact this can make. Hopefully over the course of 2 months we will be able to make all this happen, and we also hope that the deliveries, the takeaways from our conference will be very specific. When we were implementing one specific kind of screening for MA diseases 2 years ago, it took quite some time to kick off, so implementation of healthcare, implementation of specific regimes and all related things takes time. What I enjoyed a lot was the message that we heard here, because we were not focused mainly on cardiovascular diseases, but on cardiovascular health. And this is what is important. We need to focus on prevention and on health, not on treating diseases. We also mentioned several times the word trust. This is what we need to improve in Czechia mainly, but it's probably applicable to other countries too. We need to explain that this is not about some kind of pharma lobby. This is about the health of each and every one of us. I hope the topic will resonate also at the European institutions level, and that everybody in terms of what they are able to do will join the Prague Declaration, so that the health of the European Union can improve in the future, and that it will be one of the priorities, for example, the socio-economic benefits. The implementation of FH screening beyond the border of the EU is, I believe, an ambition which is doable. Obviously, it will be a little bit more difficult. Last but not least, I would like to thank FH Europe and also all the participants and panelists. I would like to also thank Mr. Freiberger and also Professor Vrablik. I should have mentioned ladies first, so I do not want to be incorrect. So I would like to thank Mrs. Chimicka and Mrs. Chilikova. Thanks to you, children with this hereditary disease can be saved, hopefully. Thank you all once again, and I hope to see you very soon so that we can continue working on this topic, so we can do the accounts, we, the politicians, the health insurance companies, to see that it has happened in reality. Thank you very much.
Thank you very much, Dr. Kraus, for those really powerful words. What a close to the meeting. As the overall moderator, I can only echo the gratitude of the organisers to everyone involved. And at this point, I would also like to thank the interpreters, the technicians and the Senate team, and particularly Christy and Spella for all of their work. I hope you've really enjoyed and learned a lot from the discussions, as I have. It was a true meeting of minds today, and this bodes extremely well for the upcoming major milestone in 3 days, where FH Europe will present FH Paediatric Screening at a best practice marketplace to Member States representatives. This is the meeting that is organised by the European Commission, and we hope that this will provide important funding in a number of Member States to really set things in motion. So let's close this historical meeting and start the signatures on the FH wall. For those of you who are online, there will also be opportunities for you to sign in the next few days, so watch this space. Thank you all once again. Safe travels back to your homes and your families, and let's continue our important work together. Thank you all.